Happy World Patient Safety Day. We are meeting today to celebrate this landmark day with new energy and new commitments to move towards zero harm in healthcare. My name is Neelam Dhingra, and I'm the unit head of WHO Patient Safety Flagship. It's my great pleasure to welcome you all to this WHO Virtual Global Conference to work together for safe and respectful maternal and newborn care. This is to celebrate the World Patient Safety Day 2021. I have the great honor and privilege to co-moderate this event with Sir Liam Donaldson, WHO Patient Safety Envoy. Next, I will briefly go through the housekeeping slides to share some important points related to this virtual conference. First, a few words about interpretation. You can access the interpretation in Arabic, Chinese, English, French, Russian, and Spanish by clicking on interpretation button and choosing the language that you would like to hear. To hear the interpreted language only, clear mute original audio. I would like to share a few words how the question and answers work. If you have a question for a specific speaker about the presentation or the topic, please write your questions in the Q&A box. If you would like to ask questions related to logistics, certificate of attendance, or IT issues, please use the chat box. And I would also like to share a few words about this session being recorded. Please note that this session is recorded and your attendance is your consent to be part of this recording. The recordings will be shared after the session in Arabic, Chinese, English, French, Russian, and Spanish. A certificate of attendance will be available through the University of New Mexico via link in the chat at the end of the session. If you fill out the feedback form finally. And moving ahead, I would like to mention that this session is organized in collaboration with Project ECO. In the next 4 hours, we have speakers from around the world to reflect how we can come together, share experiences, and learn to make maternal and newborn care safer and respectful. In the opening, we have a message from WHO Director General, Dr. Tedros. Right Honorable Mr. Jeremy Hunt and Right Honorable Ms. Helen Clark will provide keynote addresses, followed by sessions which will focus on global landscape and WHO initiatives on maternal and newborn health and safety. In the next session, the theme is prioritizing maternal and newborn safety in the context of UHC. And we have speakers reflecting patient safety in maternal and newborn services from different perspectives, as well as in 2 panel discussions. The first panel discussion is, what shall countries do to prioritize safety agenda in maternal and newborn care? And the second panel is on role of partners in advancing the safety and respectful care agenda in maternal and newborn health. We are really honored to have such a prestige list of speakers this afternoon. Before we proceed with the program of the conference, we would like to see where you are coming and connecting to this conference today. If you would like to share with us, those who are joining today, please take this exercise. Please participate in the poll. The ECO team has posted in the chat box a link. Please click the link, and this will navigate you to a browser window with a map. Please click the country in the map, but if you can't click the country, please feel free to write the name of the country in the chat box. After you have finished responding, please exit your browser window and return to the Zoom application. We will give about 15 to 20 seconds for this exercise. It's indeed great to see the world coming together across all regions for safe and respectful maternal and newborn care. Now, moving on the agenda, I have the great pleasure to invite Right Honorable Mr. Jeremy Hunt for his keynote address. Mr. Jeremy Hunt, MP, is the chair of the House of Commons Health and Social Care Select Committee in England, UK. Between 2012 and 2018, Jeremy served as Secretary of State for Health and Social Care in England, UK, making him the longest serving health secretary in British political history, following which he also served as the UK Foreign Secretary. Under Germany's leadership, the UK government initiated with Germany in 2016 the annual Global Ministerial Summit series on patient safety. This in turn facilitated action by the UK government to lead the way in securing the 2019 World Health Assembly landmark resolution on global action on patient safety. So we owe Germany, Hunt, and UK government a debt of gratitude for putting patient safety high on the global health agenda. Germany continues to support this agenda as the co-chair of the WHO World Patient Safety Day Steering Committee. Germany, the floor is yours.
Thank you, Neelam, and hello everyone, and welcome to this very exciting moment, our third ever World Patient Safety Day. And it's never been more important actually than in the last year when we've been thinking about infection prevention and control. We found here in the UK that in many hospitals between 20 and 40% of their COVID patients actually picked up the infection inside a hospital. And of course, all of you on this call today will know that preventing avoidable harm and death has been a long neglected problem in modern healthcare systems, which under the leadership of Dr. Tedros, with Neelam's extraordinary support, is now coming center stage thanks to the World Health Organization. And let's just remind ourselves of the scale of the problem. 2.6 million avoidable deaths every year outside pandemics, year in, year out, because of medical error. In England, we think that's about 150 avoidable deaths every week, and we're probably about average amongst developed countries. But I think of not just the statistic, the fact that, as Neelam tells me, it is one of the top 10 killers worldwide, causing a larger global burden of disease than malaria or TB, and almost the same burden of disease as HIV/AIDS and road traffic accidents. But also the individual people. I remember meeting a young father whose son died a week old, and he had to write 400 letters to the NHS before he was able to establish the truth about why his baby died. I met a daughter who wasn't able to say goodbye to her mother after she died because she got C. diff so badly, she was zipped up in a body bag and they wouldn't allow her to open the body bag. I remember meeting a father whose son killed himself just 300 yards from his front door because he hadn't been able to access mental health treatment early enough. And it's those human tragedies that I think is what really drives all of us to care passionately about improving patient safety. And I want, despite those horrible stories, just to give you some reasons to be optimistic. And the first really big reason to be optimistic is that we are all talking about a problem that previously has been really swept under the carpet. There's been a worry in healthcare systems that if you talk openly about mistakes, you will reduce public confidence in your institutions, in your hospitals, in your GP surgeries, and that's dangerous. And I think we've changed that because of everyone who cares about patient safety. We say something different. We say, look, if we want our healthcare systems to be the best possible, then the first step is to be open and transparent about where the problems are. And that is a very, very different approach to what has been normal practice in medicine. And I think that's the first reason for optimism. The second reason for optimism is that we are really getting much smarter at understanding what needs to change in terms of clinical practice. And I think we've understood that it isn't just about the practical things you need to do, hand washing, infection prevention and control, all the really important parts of safe, high quality care, but it's also the cultural things. It's getting rid of a blame culture in medicine, where doctors, nurses, midwives are worried that if they're honest about making a mistake, they'll lose their job. and replacing it with a learning culture, so that when there is a tragedy, the number one priority is to redesign a system to try and make sure that tragedy could never happen again. And time again, when you meet families who've been bereaved by a terrible tragedy, the one thing they ask for is they say, look, it's not about money or compensation. I just want to know that the hospital, the system has learned from that mistake and it can't happen again. And we are seeing those changes in clinical practice with inspirational leadership on the ground. Hospitals like Virginia Mason in Seattle, Salford Royal in the north of England, the northwest, many other countries. In fact, I think in nearly every country you can find hospitals where they have pioneered a learning culture and made huge strides in patient safety as a result. And then the third reason for optimism is really that this has now become a global movement. Just look at that map behind Neelam that you can see on your screens. Look at all those marks of the countries that care about patient safety. This is not just a few people. This is an ethical movement of doctors, nurses, clinicians, healthcare system leaders, families who suffered tragedies, coming together and saying that actually this is one of the easiest things we could sort out. I mean, we're not looking for a cure in the way that you need for new cancers or other diseases. We just need best practice to be followed, and we could save millions and millions of lives. So I want to leave you with the words of a very wise man who I dealt with when I was actually British Foreign Secretary a lot, taught me a lot. That's Dr. Henri Kissinger. And he had a word to describe diplomacy. He said, diplomacy is the patient accumulation of partial victories. Well, I think that's the same for the patient safety movement. The patient accumulation of partial victories. We are thinking a lot about maternal and newborn safety. We've made a lot of progress, but sometimes it's frustrating that the victories are not whole victories, they're only partial victories. Sometimes the patience it takes to get to our goal is very exhausting. But if we stick at it, that patient accumulation of partial victories will save many, many millions of lives. So thank you for your support for this amazing agenda.
Thank you very much, Jeremy, for your very powerful and inspiring words. We are indeed very honored and thankful for your leadership and support. Next, we have a message from Dr. Tedros, WHO Director General. We thank him immensely for his commitment to patient safety. Could we have the video, please?
This year's World Patient Safety Day on the 17th of September is dedicated to safe maternal and newborn care. Childbirth should be a time of celebration for families and communities. But for too many, it is a time of sorrow and grief. Every day, nearly 5,400 babies are stillborn, and more than 800 women and 6,700 newborns die mainly around the time of childbirth. These deaths are mostly avoidable with safe and quality care, delivered by skilled health professionals, supported by a strong health system. The Global Patient Safety Action Plan 2021 to 2030 provides strategic direction to eliminate avoidable harm in healthcare. WHO has also established a global network of partners for improving quality of care for maternal, newborn, and child health. To mark World Patient Safety Day every year, monuments around the world are lit up in orange as a show of global solidarity. This year, let's paint the world orange for safe maternal and newborn care. We call on all countries, health workers, communities, and partners to act now for safe and respectful childbirth.
Thank you, Dr. Tedros. Dr. Tedros is actually going to join us today, but he had to go for a country mission, and he gives us all his greetings and best wishes for the day. Moving on, I'm very honored to have the next speaker to provide us the keynote address on the role of partnership in ensuring safe and respectful childbirth. Right Honorable Ms. Helen Clark is a former Prime Minister of New Zealand, and between 2009 and 2017, she was leading the United Nations Development Program. More recently, she has co-chaired the independent panel for pandemic preparedness and response. Right Honorable Helen Clark is the board chair of the Partnership for Maternal Newborn Child Health, and I have the pleasure to hand over to her to share her views about how do we take forward the partnership for ensuring safe and respectful childbirth. Helen, the floor is yours.
Well, thank you so much, and greetings everyone from New Zealand, and a great pleasure to speak on behalf of the Partnership for Maternal, Newborn and Child Health, PMNCH for short. Sadly, we see a lot of work to be done to guarantee safe and respectful care for maternal and newborn care. There is still a significant amount of maternal mortality around our world and at the newborn state. And the burden of that is carried largely by those who live in low and middle income countries, and most particularly by those living in conflict settings, including, of course, those who are internally displaced and also refugees who've moved across borders. We see the figures that maternal mortality increases by an average of 11% in all conflict settings, and by 28% in severe conflict settings. Of the 10 countries with the world's highest neonatal mortality, 9 are in a state of conflict. So let's remember, when we see those dreadful conflicts on our television screens, that part of that story are women and newborns going without the care that they need. Now, COVID has been, of course, a setback because of the disruption to the delivery of essential services, and those include sexual and reproductive health services. The WHO has done a great service in surveying countries about disruption to these services in the period of COVID. And the first 3 months of this year, it reported that more than a third of the 121 countries responding to the survey had disruption. And then you start to see countries reporting increases in maternal deaths, particularly among the poorest people. And stillbirths are now estimated to be 1.29 times more likely in low-income and middle-income countries than they were before the pandemic. But of course, much of the mortality and the injustice and the inequality could be prevented with improved patient safety and respectful care. So that's where we have to put our focus. Sadly, many women giving birth are also experiencing unsafe, disrespectful, abusive, and even neglectful treatment. Some experience a lack of confidentiality and gross violations of privacy. Others are refused admission to health facilities and suffer life-threatening complications, as well as the direct impact. This, of course, undermines organisational reputation, staff morale, and public trust, and discourages people seeking the services they need. We've seen the disrespectful care become more frequent during COVID. Examples include not being able to have a companion with you at the time of birthing. We see reports of cesarean sections being performed on women who've tested positive for COVID, and then the separation of the mother and the child, not allowing breastfeeding, reducing the length of stay with fewer home-based follow-ups. These are all consequences. So at PMNCH, we are a partnership, more than 1,000 member organisations with the shared vision of securing health and well-being of women, children and adolescents. And part of our current strategy is prioritising policy, service delivery and financing to support safe, respectful and high quality maternal and newborn health, no matter where in the world. We have advocated for mothers and for newborns in our COVID-19 call to action, and we've made specific asks for better service delivery, quality of care, better human resources for health and for safe facilities. But obviously, partnerships are needed across sectors, across stakeholders. We are seeing some good news with mitigation strategies being put in place in the context of the pandemic, including triage and risk screening for symptoms of COVID and improving patient flows to reduce waiting times for services. We're seeing healthcare providers where they can, using virtual consultations and telehealth for counselling, shared decision-making, management of complications. We're seeing drive-through and walk-in screening tents, reducing waiting times for tests, decongesting waiting rooms, freeing up facilities to treat other health issues. These are all important innovations in getting safe and respectful care. But as always, more needs to be done, and the healthcare workforce needs our support. It is at the very heart of safe, high-quality care. At PMNCH, we urge every country to strengthen the human resources in health, to build and maintain that competent, compassionate, committed workforce we all want. That workforce needs supportive supervision, it needs fair compensation, it needs protection from bullying and harassment. There are such clear links between the safety of patients and of health workers. Our health workers have experienced increased anxiety, stress, burnout, and that has knock-on effects on the quality of care that they can provide. And let us stress the importance of vaccination for our healthcare workers. We have such an equitable rollout of the COVID vaccines around the world, and many of our healthcare workers remain unvaccinated at this time. Let me give a particular shout out to our midwives. So critical. Birthing goes on through a pandemic, and our midwives have been on the front line. We are estimated to be likely to be 1 million midwives short by 2030. How will we cope? How will we give safe and respectful care to women and to newborns? So critical to invest across all partners in supporting services during pregnancy, childbirth, and that first month of life. It brings so many benefits, literally saving the lives of mothers and newborns, reducing disabilities, and paving the way for optimal child development and lifelong well-being. With effective partnerships, with commitment and innovation, we can and we must ensure patient safety for women and newborns around our world. And at PMNCH, across our 1,000 partners, we are dedicated to that. Thank you.
Many thanks, Helen, for your very inspiring words that can guide all of us in the journey of ensuring all women and newborns receive safe and respectful care. Next, we have the WHO World Patient Safety Day campaign video. Could we have the video, please? Hope you enjoyed the video. Such a moment of joy and hope. Moving on, I have the pleasure to introduce Udie Soko, who is a patient safety advocate and a member of the WHO Advisory Group for Patients for Patient Safety. Udie is the founder and executive director, Zambian Cancer Society, and she's going to share with us a few words of her personal story, how her family member was harmed in childbirth. Udie, over to you, please.
Thank you very much. Good day. The headline of a Zambian online newspaper on the 15th of September 2021 reads, "Maternal deaths worry Ministry of Health." A short quote from the story says, "The Ministry of Health has disclosed that 10 to 15 women die every week due to maternal-related issues. Dr. Silomesi, who is in charge of public health, says he regrets that the situation is the same for children." He was speaking during a familiarization staff meeting with the new Minister of Health, Sylvia Masebo. Right, I was trying to share my video earlier. I'm glad I'm on now. Growing up as a young girl, I would fairly often hear a local word, Mwapusikeni, said to every woman who successfully delivered a baby. I later learned that this means you have survived. As a young person, I would wonder, why would a woman not survive childbirth? Of course, as I grew older, I understood that pregnancy, childbirth, and even bringing up a baby is not to be taken lightly, even though I do not have any biological children of my own. And yes, while occasionally I would hear of a mother dying during labor, this issue of maternal death and newborn care was not top of my radar until a few months ago, May to be exact. I vividly remember receiving a call from my nephew in the early evening, informing me that his pregnant elder sister, called Violet, had been taken by ambulance to one of our major teaching hospitals. This was after her local clinic, where she had gone to first, realized that attending to her condition was beyond them. He informed me that he and his wife were keeping vigil, as the medical staff had said his sister appeared to be having a miscarriage. A couple of hours later, he called me to say that he and his wife were leaving, as advised by the doctor, because it looked like his sister would be in an induced labor state for quite a long while. And them being there was not helpful and also was not advisable, as Zambia at that time was in the midst of a devastating third wave of the COVID-19 pandemic. My nephew and I said our goodbyes, but neither of us got much sleep as we anxiously awaited news of my niece's labor. At around 6 a.m. the following morning, the wait was over. I received the dreaded news that his sister, my late brother's daughter, had died in theater. Holding back my tears, I asked, "What about the baby?" "Auntie, the baby too is dead." I could not believe it. I went numb with shock. 2 days later, we buried Violet. It was all a blur. Post-burial, in our quest to seek answers about these deaths, from the home front and the hospital front, this is what we gathered. Number one, whilst it was Violet's 4th pregnancy, she chose prenatal care to be done by a private Chinese clinic rather than going to her usual government one, following suit where several of her friends had been attended to. Number two, a week before she died, she confided in a cousin that she had gone for a scan at the Chinese clinic, where she was told that the baby was a girl, but was not moving. Number three, she went to the government main hospital by ambulance, minus any medical records. Number 4, her induced labor was protracted, accompanied by severe pain and very high blood pressure. Number 5, the baby was born naturally, but stillborn. Number 6, the baby's appearance was that of one that had died more than a week ago. This prompted the doctors to take Violet to theater for a hysterectomy, as a scan after she had delivered showed that her uterus had gone through a lot of trauma. During the operation, she suffered severe bleeding and died. The short version of her cause of death, according to her death certificate, was ruptured uterus. What could have been done differently? We have so many thoughts, but here are a couple of things that have gone through our minds. At the private facility, surely the baby was not moving. That was a red flag. Could the doctor have not done more to ensure that this patient seeks more or advanced medical help? Could the doctor not have reached out to the next of kin to ensure that this patient is seen at a more sophisticated health facility? At the public health facility, at the clinic, it's a clinic where Violet had been going for 14 years. And yet when she went into the ambulance, she had no medical records. We need better record keeping, perhaps moving to electronic records, especially at the lower level health facilities. And really, who knows what happened at the central hospital, at the major health facility. A scan was done after she gave birth. Could it have been done before? We were not privy to what was going on there. So we have a lot of unanswered questions. And for the family, what lesson have we learned? To use this experience, as painful as it is, to ensure other members of the family in particular are monitored closely during pregnancy, delivery, and after birth. Violet left behind 3 beautiful children, aged 14, 10, and 3. Whilst they do not have a biological mother anymore, we as a family are committed to raising them to the best of our ability. May Violet's soul rest in peace. Thank you.
Udie, really sorry for your tragic loss, and many thanks for sharing your story of harm and suffering. And you also shared with us some measures you as a patient advocate can take, and we can all take to help prevent harm in childbirth. So moving on, I have the great pleasure to show 2 videos from WHO regional directors on the occasion of World Patient Safety Day. First, Dr. Moeti, Regional Director for Africa, will provide her remarks. Could we have the video, please?
The theme of World Patient Safety Day this year, Safe Maternal and Newborn Care, is incredibly relevant in the African region, which accounts for nearly 7 out of 10 maternal deaths and 1 out of 3 newborn deaths globally. Many of these deaths could be prevented by making sure that patients feel safe, respected, and that their needs are heard and acted on, and by equipping health workers with the knowledge, skills, and tools to take life-saving action. Women, in particular, are confronted with a range of challenges as patients. They face physical and verbal abuse and exclusion from decision-making about their care. For instance, during childbirth, pregnant women are often denied the choice of having a birth companion present or to deliver in their preferred birthing position. Newborn rights to quality care, for example, largely go unprotected. During the pandemic, some people have avoided seeking care in health facilities for fear of catching COVID-19 or other infectious diseases. To combat this hesitancy, health systems need to work on building community trust and investing more in good infection prevention and control practices. Care should be provided with compassion and respect by health workers with the skills to succeed, and in clean and safe environments that prevent the spread of infections. As WHO, we are working with countries to make this happen by implementing the WHO Global Patient Safety Action Plan 2021 to 2030. Ethiopia, Ghana, Malawi, and other countries have developed national quality strategies to improve practices and enhance accountability. Eswatini, Lesotho, and Kenya are among countries adopting integrated approaches to service delivery built around the needs of patients. By engaging patients as partners in the provision of quality care, health systems will make tangible progress towards universal health coverage. So, this World Patient Safety Day, I encourage all stakeholders, governments, civil society, the private sector, health workers, and communities to speak up for patient safety and to act now for safe and respectful childbirth.
Thanking Dr. Moeti for her commitment and support on this World Patient Safety Day. Next, we have a message from Dr. Ahmed Al-Mandhari, WHO Region Director for the Eastern Mediterranean. Could we have the video, please?
Bismillah ar-Rahman ar-Rahim. This year, as we celebrate World Patient Safety Day, we are asking everyone to act now for safe and respectful childbirth under the theme of safe maternal and newborn care. Maternal and neonatal mortality is unacceptably high. Even before the pandemic, approximately 810 women globally died every day from preventable causes related to pregnancy and childbirth, and 7,000 newborns died daily. The maternal mortality ratio in WHO's Eastern Mediterranean region is the second highest globally. 164 maternal deaths per 100,000 live births. And we also have the second highest rate of neonatal mortality at 25 deaths per 1,000 live births. Ongoing conflicts and instabilities in our region prevent thousands of women and their babies from receiving the quality of care they deserve. Most deaths and stillbirths could be avoided through the provision of safe care delivered by skilled healthcare professionals working in supportive environments. But the COVID-19 pandemic has reduced access to essential care for pregnant women and newborns even further. We call on expectant mothers to reach out to their healthcare team to ask for information related to safe and respectful delivery that they deserve. We call on spouses, families, and communities to speak up for safe and respectful maternal and newborn care, that they adhere to safety precautions for COVID-19. We call on health workers to strive to make childbirth a positive experience for all women and newborns by providing safe and quality care. We ask healthcare leaders and facility managers to create an enabling environment for safe and respectful maternal and newborn care, and policymakers and program managers to prioritize safety in maternal and newborn services and provide resources for safer healthcare systems striving for health for all by all. We need to act now. Wassalamu alaikum wa rahmatullah wa barakatuh.
Thank you, Dr. Al-Mandhari. So with this, we come to the end of the opening session of this global conference. And I would like to take this opportunity to thank all the speakers and all the leadership from WHO for sending us their extremely important and inspiring messages and for their commitment and leadership. Moving ahead to session 1, which is Global Landscape and WHO Initiatives on Maternal and Newborn Health and Safety, I would invite my co-moderator, Sir Liam Donaldson, to take the floor and moderate the next session. Sir Liam, the floor is yours.
Thank you very much, Neelam, and good afternoon, everybody. The front line of delivering safe maternal and newborn care is about teamwork. Every member of the team
bringing their skills and working together in a cohesive way is the way to success and the way to preventing harm. And similarly, when we look at the global landscape in promoting the concept of safer maternal and newborn care, we look to teamwork again, and we look to the directors of the different departments of WHO, the WHO's regions and the WHO's country officers. So we're going to now survey that global landscape and hear from the leaders within the WHO system that bring their different perspectives to an overall team that's there to try and achieve this successful goal of safe maternal and newborn care. So we're going to start by hearing from Dr. Anshu Banerjee. Anshu is the director of the Department of Maternal, Newborn, Child and Adolescent Health and Aging in the WHO headquarters in Geneva. So over to you, Anshu, for your remarks.
Thank you very much. And it's a pleasure to be part of this year's World Patient Safety Day, which has as its theme, safe maternal and newborn care, and as its slogan, act now for safe and respectful childbirth. I'll give a quick overview of the landscape in maternal and newborn health. Next. In 2017, an estimated 295,000 women died due to complications of pregnancy and childbirth. And although there has been a 38% reduction in maternal deaths since 2000, the average annual rate of reduction between 2000 and 2017 was only 2.9%. And this is not enough progress in order to achieve the SDG target by 2030. Next. We also had a similar substantial progress in child survival since 1990. Globally, the number of neonatal deaths declined from 5 million in 1990 to 2.4 million in 2019. However, this decline in neonatal mortality has been slower than the post-neonatal under 5 mortality. And therefore, neonatal mortality at the moment is currently almost 50% of under 5 deaths in 2019. So that means 50% of children under 5 die in the first month of life compared to the subsequent 59 months of life. Next slide. And in 2019, there were also an estimated 2 million stillbirths worldwide, which are mostly invisible in the global health agenda. Although the highest burden of stillbirths is in low and middle income country settings, stillbirths affect all countries. There's, however, a lot of inequity, and there's a 23-fold difference between the highest and lowest burden countries. Stillbirths are more prevalent in vulnerable populations, and this also applies to high-income settings. Next. In addition to this, of course, the COVID pandemic may have reduced the gains that were made to date, and this is because during the pandemic, there have been disruptions in essential health services. This graph shows that there was still substantial disruption in reproductive, maternal, newborn, child, and adolescent health services between January and March 2021, based on the second round of the national pulse surveys conducted by WHO. Accelerated action will be needed to achieve the SDG targets by 2030. Next. Now, maternal and newborn mortality is only the tip of the iceberg, with many more women and newborns experiencing morbidity, disability, and long-term ill health, many of which could be prevented with improved quality of care during pregnancy and childbirth. Next. It is estimated that half of maternal deaths and 58% of newborn deaths could be averted with quality of care. In addition, almost half of stillbirths actually occur during childbirth. WHO therefore developed a framework for improving the quality of maternal and newborn healthcare. It takes a health systems approach and comprises 2 elements: provision of care and experience of care supported by underlying health systems components. WHO has also developed standards for improving quality of maternal and newborn care overall, but also specifically for small and sick newborns in health facilities. Next. And WHO has recommendations across the continuum of care, from antenatal care to interpartum care and postnatal care. The last one on postnatal care is currently being updated and will be released early 2022. All guidelines focus on clinical care as well as on promoting a positive experience of care in line with the quality of care framework. Next. One essential element of quality of care is that in some settings there is not enough care, and in other settings there is an overuse of care. This slide shows the cesarean section rates in different countries. In low-income countries, there is limited use of cesarean section, and this is most likely because services are not available to all, while in other countries, mostly in middle-income settings, there are high rates of cesarean section as part of over-medicalization of healthcare. Next. Another essential element of quality of care is improving water and sanitation in health facilities. It is estimated that 1.8 billion people use health facilities that lack basic water services, and 800 million people use health facilities with no toilets. WASH, or water and sanitation and hygiene, is essential for infection prevention and control, and the COVID pandemic has highlighted this even more. Next. Therefore, WHO is developing a new training package on IPC standards and practices, which comprises of 6 modules. And today, the first module on the basics of infection prevention and control is being launched. Next. Ian Askew, the next speaker, will focus more on maternal health, and therefore I'll just highlight in a minute what we are doing on newborn care. There are a variety of essential high-impact neonatal interventions to ensure quality of care, including no separation from the mother, or no separation between mother and baby, promotion of breastfeeding, optimal nutrition, comfort and nurturing care, and safe management of illness, including for small and sick newborns. This is a key package of interventions that we should be able to provide to newborns. And singling out one particular one, kangaroo mother care, is particularly for low birth weight infants. And a recent study has demonstrated that starting kangaroo mother care soon after birth improves survival of babies with birth weight less than 1,800 grams by 25%. And this is before stable, even before the newborn is, let's say, stable. And this intervention really needs to be scaled up. Finally, next slide. Oh, sorry, we're 2 slides. Next slide. Finally, improving maternal and newborn care will require partnerships among all, including engagements with the private sector and patient advocacy groups. We look forward to working with all of you for safe maternal and newborn care. Thank you very much.
Thank you very much indeed, Anshu, for that overview of the global landscape in maternal and newborn health. And you spoke there of what Jeremy Hunt described as the partial victories, but also highlighted the many challenges still ahead and the areas where progress has been a lot slower than we would like. But thank you very much indeed for that. And we move on next to another of the WHO's directors, Dr. Ian Askew. Ian is director of the Department of Sexual and Reproductive Health and Research, and also has a major role in a special program involving United Nations agencies and the World Bank, looking at research development and research training in human reproduction, which is also based at WHO headquarters in Geneva. Ian.
Well, thank you very much, Sir Liam, and to my colleague Anshu. I wanted to spend a little bit of time talking about respectful care and what do we mean by respectful childbirth, because for ourselves at WHO, this is such an integral part of patient safety. But I wanted to pull out some of the key elements to really bring home why this is such an important aspect to look at. Next slide, please. First, women everywhere want respectful care. 2 years ago, the White Ribbon Alliance carried out a major campaign and surveyed 1.2 million women around the world in 144 countries. And the #1 request when asked, what do you want for quality reproductive and maternal health services? The #1 request was for respectful and dignified care. And women mentioned they wanted strong interpersonal communications. They wanted kindness, courtesy, compassion. They wanted to feel valued, heard, and acknowledged. But also they wanted bad behaviors, and particularly being stigmatized and discriminated against. They wanted these behaviors to stop. So we know that if any part of a safe care has to include a respectful component to it and be delivered respectfully to women everywhere. And why is this? If you look at the next slide, please. A study that was carried out quite recently in 4 countries showed that mistreatment during childbirth is extremely common. In this survey, more than 2,000 women were observed during their labor and childbirth in health facilities, and 42% of them were observed to experience physical or verbal abuse or being stigmatized and discriminated against. And this was particularly prevalent during the 15 minutes before birth, when the physical or verbal abuse really stepped up. We also found from this research that younger women were almost twice as more likely to experience physical abuse, and that women with no education were 3.6 times more likely to experience verbal abuse. The study also showed that many women experienced procedures without giving their consent. We saw that 11% of women experienced a cesarean section without giving consent, 56% an episiotomy, and 27% induction of labor. So mistreatment is very common, and it's some part of childbirth care that has to change. Next slide. So in addition to being something that women want, respectful care is clearly a human right. A number of documents and consensus statements have come out recently to really bring home that a human rights-based approach to mistreatment and violence has to be addressed and integral to countries' approaches to providing childbirth services. At the General Assembly of the UN back in 2019, there was a statement put forward by the Secretary General. And in the same year, the Parliamentary Assembly for the Council of Europe also put out a statement about obstetrical and gynecological violence. So from a human rights perspective, there are many strong positions that countries can use to guide their services. When we've looked at an analysis of what does it mean to have a human rights approach, 3 broad aspects emerged. First and foremost, engaging women in their care and being accountable for their experiences are absolutely essential for any health system that is going to be providing a respectful approach that's human rights based. Secondly, that women be treated as active and informed individuals, taking into account their unique expectations and needs. And thirdly, that the health system creates an enabling environment for women to speak up and for health providers to be able to listen to the needs and desires of women at this particular time. Next slide. In our definitions and the conceptual frameworks that you saw presented by Anshu, we really do want to promote the idea that good quality care is both safe care and respectful care. And for WHO, we've developed this definition of what we mean by respectful care. Respectful maternity and newborn care refers to care that maintains dignity, privacy, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor, childbirth, and the immediate postnatal period. And this is a fundamental construct for the conceptual framework that we've provided around quality of care. And there are a number of, as Anshu mentioned, we have put out a number of standards to try to encourage health systems to be able to offer respectful care that is safe also. Next slide. We do feel that the evidence that we brought together to try to provide recommendations around how to provide safe and respectful care can usher in a new era for childbirth practices. If you recall the video that we showed you earlier, several of the recommendations that we make and that I've presented on the screen here were being demonstrated in that video. We've organized them around 6 broad areas: effective communication, a desired companionship during the labor and the birth, ensuring that fluid and food are available throughout the process, providing continuity of care from beginning to end, ensuring that mobility is enabled and that the woman is in an upright position for most of the time, and then making sure that pain management is easily available and able to, and of a form that can treat the pain being experienced. Next slide. Finally, we want to emphasize that ensuring safe and respectful childbirth goes beyond just the service delivery interventions that I've talked about in the previous slide. It's incumbent upon societies and health systems more generally to make sure that some of what we call the structural determinants of a safe and respectful childbirth are in place. So there must be strategies to reduce mistreatment and promote respectful care that account for gender, racial, and power dynamics. And these need to include participatory partnerships with communities. It's important at societal levels to challenge the harmful gender stereotypes that sustain disrespectful care. We need to eliminate intersectional discriminations that really do make sure that some women really are discriminated against for multiple reasons. We need to disrupt the power dynamics that sustain this disrespectful care when it occurs. And we need to address the broader health system conditions and constraints that can lead to disrespectful care and prevent women experiencing a safe childbirth throughout the process. So my final slide, before I hand over to my colleague Elizabeth Iro for the next slide, is just to remind everyone that all of the things that I've just talked about and that Anshu talked about are absolutely fundamental, whether or not the woman is infected with COVID. All of those conditions have to apply, and we cannot expect that a lower standard of care is provided simply because of disruptions due to COVID. So thank you, and back to you, Sir Liam.
Thank you, Ian, and thank you to you and your colleagues for linking this concept of respectful care into the overall purpose of looking at safety for maternal and newborn care. It's something that insiders are very, very familiar with, but it obviously needs a much greater profile as far as the wider world is concerned. So an excellent concept to promote much more widely than has been the case hitherto. So thank you for your presentation highlighting that and giving us a strong conceptual framework to go on in addressing it. We'll turn now to Elizabeth Iro. Elizabeth is, of course, the Chief Nursing Officer at WHO headquarters and is going to talk to us about the role of nurses and midwives in the provision of safe and respectful maternal and newborn care.
Thank you, Sir Liam. Greetings, everyone. It's a real pleasure to be a part of this year's World Patient Safety Day conference, Together for Safe and Respectful Maternal and Newborn Care. There is nothing more important in this world than the safety of the people in it. The COVID-19 pandemic has very clearly shown us that we are very vulnerable. We have seen on many occasions that our infrastructures are weak, that our health systems are delicate, and our health workforce is fragile. The impact of this has had unimaginable consequences. Over 4.5 million people have died from COVID-19 around the world, and sadly, many lives could have been saved if there was better access to medical treatment, and especially vaccines. We have learned lessons in the last 2 years that we must address this, and we must address them now. Any death that could have been avoided is a tragedy. Sadly, healthcare workers caring for women in childbirth are no strangers to avoidable deaths. I want to remind us of some of those statistics that Anshu mentioned earlier. Approximately 810 women died every day from preventable causes related to pregnancy and childbirth. That's about 295,000 women in 1 year, and approximately 6,700 newborn deaths every day, often from preventable deaths. That's approximately 2.4 million babies in the first month of life in 1 year. 94% of all maternal deaths occur in low and middle income countries. And critically, we know that skilled care before, during, and after childbirth can save the lives of women and newborns. Nurses and midwives around the world are the primary providers of care during and following pregnancy and childbirth. Our leadership and involvement in the development of systems and guidance that drive safer care is essential, and it is our responsibility to developing a workforce that can meet the standards of a high quality service and experience every day in every country. Last year was the International Year of the Nurse and the Midwife. This year is the Year of the Health and Care Workers. And during a time of crisis and scrutiny, the work of nurses and midwives around the world has never been more visible. This gives us an opportunity to influence healthcare strategy, to lead in government and make the necessary shifts in policy and action that is needed to strengthen the workforce that cares for mothers and their newborns. The Global Strategic Direction for Nursing and Midwifery 2021-2025 and a resolution at the World Health Assembly in May this year to strengthen nursing and midwifery was a very welcome and needed endorsement. Its policy priorities in 4 areas of education, jobs, leadership, and service delivery will strengthen both nursing and midwifery. And I hope it ensures further development of nurses and midwives as leaders and experts at the most senior level. We have an opportunity to develop and expand the curriculum to create new undergraduate degree and postgraduate opportunities for nursing and midwifery. Patient safety should be an essential topic in building healthcare workers' competencies to avoid medical errors and make healthcare safer for all patients, everywhere, every time. One of our greatest challenges lies in the recruitment of our nursing and midwifery professions. The State of the World's Nursing Report in 2020, published before the onset of the pandemic, highlighted a shortage of about 6 million nurses. And we see evidence to suggest that month on month, more nurses are leaving the profession than are joining it. The State of the World's Midwifery 2021 report indicated that investing in fully trained, licensed midwives can provide about 90% of vital sexual reproductive maternal and neonatal adolescent health care through the life course, when it is enabled by an interdisciplinary team. And midwives also facilitate positive birth experiences and safe and effective comprehensive sexual reproductive healthcare services. Both midwives and nurses play a significant role in the design and delivery of healthcare systems. And we need to ensure that we understand where our workforce gaps lie in order to develop effective solutions that promote safe, high quality care in a blame-free safety culture. Building capacity within our profession and across all healthcare professionals to work effectively in multidisciplinary teams is vital. By increasing the educational and clinical capability, we also strengthen our position in service delivery, improving quality and safety, and our opportunities to provide safer and respectful maternal and newborn care. Our key messages today are clear. Invest in health systems and allocate sufficient resources for equitable access to safe and quality maternal and newborn health services. Build a competent and sufficient health workforce supported by a safe and enabling work environment. Engage with patients, communities, and civil society to establish safer maternal and newborn health services. Develop and disseminate guidance on safe and respectful childbirth. And establish reporting and learning systems to guide improvements in maternal and neonatal care. Our road to recovery from the pandemic will be slow, but we must recognize that if we are to build systems that will protect us in a time of crisis, they must be designed to protect us every day we need them. Every day women need us. 385,000 babies are born each day into a world increasingly shadowed by conflict, turbulence, and insecurity. Let us commit to ensuring that their first experience of life is one of safety, respect, and care. Thank you.
Thank you very much, Elizabeth, and thank you for reminding us of that vital role of nurses and midwives as the primary providers of care, as you put it, and for talking about the work that you're doing on leadership, culture, education, and training, but also echoing the theme of last year's World Patient Safety Day, which was about health workers and the importance of their safety and their resilience at all times, and in certainly, as you mentioned at the end there, in some of the most dangerous parts of the world. So thank you very much for that. We have another opportunity for you to give your opinion. This time it's a world cloud. So if I could ask you to go to the chat section, and there's a link in there pasted into the chat, and it'll navigate you to a browser window through which you can enter your response. And the question is, what does safe maternal and newborn care mean to you? Please just provide one answer, and you'll see from the link that if you want to make the relevant words connected, you need to use the underscore on your keyboard. So for example, if you chose appropriate infection control, you'd need to write it with the appropriate underscore between appropriate and infection, and between infection and control. So if you do that and you click submit, then we'll have a look and see how the word cloud turns out. We'll give it a few moments to do that. Well, that's moving around a bit, but you can see some very interesting words coming right to the fore there. The word patient-centered, respect, I think strongly reinforcing the emotional resonance of Ian's presentation on the respectful component of care and how sometimes that is not given the attention it needs. And of course, safe right at the heart of the word cloud as well. So thank you very much for that. Lots of detail there, which represents quite a number of votes. So let's not forget about the smaller print as well, and we can let you all have a copy of that later. So we'd like to move on to our next speaker, and it's a great pleasure to introduce my co-moderator, Neelam Dhingra. Neelam, of course, you've already heard from, introducing the overall purpose of the meeting and the earlier speakers, but her day job, as it were, is the unit head of the patient safety department within WHO headquarters, and it was a great pleasure to work with her on the creation of the Global Patient Safety Action Plan, which was launched earlier, and which will be such an important determinant of how safety for patients around the world is improved over the next decade as it becomes a flagship activity. So over to you, Neelam.
Thank you very much, Sir Liam, for this opportunity. Could I have the next slide, please? So building on to what Elizabeth mentioned, particularly on the burden of harm, the huge burden of preventable harm and human suffering we see every day, I would just like to highlight why safety is so important in maternal and child health. You know, we see that significant harm is concentrated around the 48 hours of childbirth. Safety incidents lead to mistrust and diminished health seeking behavior. So it's very, very important that safe care is provided for our journey for universal health coverage. And most of the harm to women and newborn actually is preventable. So that's why safety is at the center of the agenda for maternal and newborn care. Next slide, please. If we look at patient safety incidents, particularly any unintended or unexpected incident, which could have or did lead to harm to the patients. So either the actual incident reaches the patient or it doesn't reach the patient. If it doesn't reach the patient, it actually was a near miss, which could have caused harm, but didn't really reach the patient. But if it has reached the patient, it could either lead to a harm or a no harm incident. And if we focus onto the harmful incidents, there could be some which are preventable and some are not preventable. So we are focusing on reducing harm, particularly for incidents which are preventable. Next slide, please. This slide particularly shows some specific sources of harm during childbirth, which are totally avoidable with safe and quality care. Administrative errors, patient misidentification, for example. Transfusion errors, wrong blood given to wrong patient. Healthcare-associated infections, unnecessary and harmful practices, which can lead to harm, which can easily be avoided. Diagnostic errors, if you fail to diagnose high-risk pregnancies, for example, in time. Or medication errors, most importantly, wrong dose, wrong patient, and wrong site, and wrong route of giving medication. So many opportunities where things can go wrong, so many risks, but all these are preventable with systems approach to patient safety. Next, please. So let's go through some of the WHO efforts which have taken place in the last couple of years to advance patient safety agenda. WHO has launched a decade of patient safety. A decade from this year to 2030, which is aligned with the Sustainable Development Goals. And this decade of patient safety is a WHO commitment and contribution to global patient safety movement. A couple of important initiatives as part of this flagship. Of course, we heard about the Global Patient Safety Action Plan, which is a roadmap for next 10 years for action on patient safety to reduce harm and move towards eliminating harm in healthcare. World Patient Safety Day, huge platform for patient engagement, understanding of safety, as well as bringing global solidarity for action. Medication Without Harm, the third WHO Global Patient Safety Challenge, as a very important change management program to address unsafe medication practices. Global Patient Safety Collaborative, a unique pioneering model of collaboration between UK government and WHO, where some focused attention is given to safety issues, and priority countries are collaborating with WHO and academic partners, Imperial College, for developing safer systems in healthcare. And last but not the least, extremely important, WHO guidance and tools to support initiatives globally on patient safety. Next, please. It was mentioned earlier, 2019 was a landmark year for patient safety. It was a watershed moment when the 72nd World Health Assembly adopted the resolution, WHO 72.6. And that was a resolution which also mandated and established the World Patient Safety Day to be observed annually. This year, the 74th World Health Assembly adopted a decision for adoption of the 10-year roadmap, which is the Global Patient Safety Action Plan. And these actually provide now the foundation for global efforts and WHO efforts on patient safety action. Next, please. If you look at the overview of the action plan, it provides us the vision and as well as the mission and the goal, identifies key partners, which are governments and healthcare facilities and services, all stakeholders, civil society organizations, professional bodies, and of course, WHO through all its level of the organization. And the action plan also identifies 7 guiding principles, which are the foundation when we are strengthening systems for patient safety. The vision which it gives is exactly what has been said and resonated since morning, since the session started, of safe and respectful care. A world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. with the overall goal to achieve the maximum possible reduction in avoidable harm due to unsafe care globally. Next, please. The action plan provides 7 strategic objectives, which give a very comprehensive and systems approach to patient safety. How we can develop systems and strengthen systems which are based on safety through policies to eliminate avoidable harm in healthcare, high reliability systems which are applying human factors as well as ergonomics principles, safety of clinical processes by identifying risk-prone clinical processes and ensuring safety in these processes. Patient and family engagement and patients and families being the co-producers of health. Health worker education, skills, and safety, particularly to empower health workers so they are committed and they have compassion and the skills and competence, and their own safety is also looked after. Information, research, and risk management, particularly through establishing reporting and learning systems and learning from harm and errors and mistakes. And last but not the least, working together to synergy, partnerships, and solidarity. And these 7 strategic objectives provide the framework, and under each of these, there are 5 key strategies under which action is defined. So the Global Patient Safety Action Plan is a framework of 7x5 metrics, which addresses patient safety in a very comprehensive and systematic approach. Next, please. So moving on to the actual focus of this year's World Patient Safety Day, safe maternal and newborn care. Next, please. And it's really my privilege, honor to share with you that we are launching the World Patient Safety Day Goals 2021-2022, which spans the year of the year of 21 till the next World Patient Safety Day. Basically, focus action for this year for safe maternal and newborn care. Next, please. The World Patient Safety Day Goals is an annual call for improvement around the theme of World Patient Safety Day. It's linked with high priority or high impact interventions, particularly based on recommendations which are already being provided by WHO guidance and materials, but it's targeted for action at the point of care, at the healthcare facilities and the providers. It's accompanied with process and outcome measures so that we can see how we are progressing during the period of 1 year. And by the end of 1 year, we hope and if the envisage that these goals will become routine practice in these healthcare facilities. And then we also promote healthcare facilities to sign up to the goals and share their stories. Next, please. So the 5 goals which we are launching today, a set of 5 World Patient Safety Day goals dedicated to safe maternal and newborn care, is reduce practices that are unnecessary and harmful to women and newborn during childbirth, strengthen capacity and support of health workers for safe maternal and newborn care, promote respectful care for safe childbirth, improve safe use of medication and blood transfusion during childbirth, and report and analyze safety incidents in childbirth. Next slide, please. So with this, I would like to thank you for your attention for this short presentation, but we look forward to our collective global efforts in realizing the vision of eliminating harm in healthcare, particularly focused this year of eliminating harm in maternal and child care, so that we could actually see moments of joy and happiness around the world. Thank you. Thank you, Sir Liam.
Thank you, Neelam. And some very concrete goals for the year ahead. This is the third, as you know, the third World Patient Safety Day. And I think the first time that we've come up with a program of work for the year. So that's a very, very important thing. But even more importantly, World Patient Safety Day is one day, one very important day. But Neelam also set it in the context of the 10-year strategy for improving patient safety, where we will be looking at improving safety every day in that 10-year period. And that's a very inspiring thought. So we've talked a lot about the role of WHO headquarters and its regional officers. People outside WHO are pretty familiar with those 2 elements of the WHO structure. They're not always so familiar with the role of WHO country officers. And they do play a very vital role around the world. They're maybe not so publicly visible, but we're going to hear now from, in a video from the WHO country office in the Philippines.
May mga patient po kami na late po talaga magpa-check up kasi nung una po talaga, ang nire-reason out po nila yung COVID.
Colleen, a 24-year-old midwife from Dasmariñas City, Cavite, shares that the pandemic has created fears among mothers, leading to delays in seeking proper prenatal care. She works at the Dasmariñas City Health Office lying in clinic in Cavite, which was built just last year to cater to pregnant women. Due to COVID-19, the public hospital no longer admits expectant mothers because hospital beds have been dedicated to care for COVID-19 cases. Since hospitals are filled with COVID-19 patients, it has been difficult for pregnant women to seek facility care. These carry a lot of dilemmas and questions of safety and access for both mothers and health workers. That is why, for their safety and accessibility, the local public hospital refers pregnant mothers to the lying-in clinic.
Halimbawa po may mga nag-positive po sa amin or quarantine. Since understaffed po kami, syempre yung mga health worker medyo pagod na rin po. Nag-straight duty lang po talaga kami. Wala pong nagsasab.
Strict infection prevention measures are enforced to make sure no one gets infected, just as Colleen fears that she or any one of her fellow staff from the clinic may potentially expose their vulnerable patients. To add a level of protection and put mothers at ease by ensuring safe services, the staff have also been fully vaccinated.
Sumusunod po talaga kami sa safety protocol po. Siyempre po, may social distancing po. Kailangan po nakaayos po yung face mask. Kada pasok rin po ng patient, nagdi-disinfect po sila ng kamay.
For Colleen, there is a great sense of relief every time she helps bring another life to this world, while ensuring that both mother and baby are safe, meaning free from injuries, accidents, and infections.
Well, there you see the work of WHO country office, and I always find it fascinating to look at more granular examples like that in the field of safety. And you can see there how they're very strong in pursuing the basics of good antenatal care and infection prevention and control, with obviously the added dimension of COVID there with the vaccination program. But getting the basics right is as important as it's always been, but matched with some very modern things, the use of social media to inform and educate expectant mothers. I think it just shows how the time-honored methods need to be married with the most modern way of communication and engagement and empowerment of patients. So thank you very much indeed to our colleagues in the Philippines for that example of the work that they're doing. I'm turning now to another of the directors at WHO headquarters to say a little bit more about Dr. Rudi Eggers. Many of you, like me, will have worked for many years with Dr. Ed Kelly, who, of course, was Rudi's predecessor as head of the Integrated Health Services Department in WHO. Ed has moved on to another field of work, but I was talking to him only this morning, and he is missing us and would very much be wishing this third World Patient Safety Day every success. But Rudi has come in as an excellent track record in his previous roles. Rudi was the WHO representative to Kenya, based in Nairobi, and he's still finding his feet, but finding his feet very quickly and already making his mark on the very important area of integrated health services. So his presentation is going to focus on maintaining safe functioning of maternal and newborn services during the COVID-19 pandemic. So over to you, Rudi.
Thank you, Sir Liam, and good afternoon, good morning, wherever you are across the world. I'm absolutely delighted to see so many people join us. As Sir Liam mentioned, of course, I was WHO representative in Kenya for the past 5 years. So this topic is quite close to my heart. I was in Kenya when the COVID epidemic started, and maintaining the essential services across the country was very important at that stage. Let's go to the next slide, please. Clearly, we all know that the disruption of the essential health services was one of the main features of the COVID outbreak. And these disruptions were to the maternal and child health services. And as we saw in the video just now, they were both on the access side, that means the availability of service side, but also in the use side, the demand from people to go to the facilities. And this has resulted, as we all know, in huge numbers of complications and deaths. In fact, it is estimated that a decline of 10% in service coverage during pregnancy and for newborns could result in an additional 28,000 maternal and 168,000 newborn deaths. Quite an astounding number. It is clear that as the epidemic broke out, and that was the case also in Kenya, that we had to balance the demands for responding to the pandemic, and this was of course forefront in everybody's mind, to the need to maintain essential health services. Let's go to the next slide. From WHO, we did two surveys called the Pulse surveys, with exactly that intent in mind, to actually measure the continuity of essential health services during the pandemic. And you can see there that 94% of countries responded that they will experience some disruptions to the services, and 9% of countries, in fact, reported extreme disruption of services. So quite considerable figures there. And you can see the figures there for the other proportions, 25%, 29 and 32. So only very few countries really managed to maintain their essential services during the pandemic outbreak. Next slide, please. These essential services were actually across the board. So not only reproductive, maternal and child health was affected, but in fact, all of the services. And in fact, maybe unsurprisingly, services such as mental health, neurological and substance abuse disorders suffered mostly. You can see that those numbers there as at the highest. And other more regular services, maybe services that people were more commonly used to, such as immunization, communicable diseases, and indeed maternal and newborn child were also severely affected, but maybe not to the extent than the others. Next slide, please. This slide was already shown by Anshu. So within the maternal, the reproductive, maternal, newborn, child and adolescent health areas, within that, there were different parts that were more seriously affected. Again, maybe quite unsurprising, family planning and contraception was one of the ones that was affected most severely, together with the management of malnutrition, the management of, or the response to violence prevention, etc. But across the board, you can see more than 25%, 30%, etc., being affected by the COVID outbreak. Next slide. The good news, maybe. Next slide, please. The good news maybe was we did these surveys actually twice. So the first one was done in mid-2020. You can see the left-hand graph there. And the second round was done in the first quarter of 2021. And the good news maybe out of this, this graph is that, in fact, we saw a positive trend, a decrease in these reported disruptions across the board. So the curve actually started to come down. And if you look at the most severely affected country, previously 24% of countries reporting to be most severely affected, and that dropping away to 8%. So as we progressed in the epidemic, and certainly this was the case in Kenya as well, the impact on the essential health services was somehow caught up and mitigated. Next slide, please. Very importantly, the service disruptions were both on the supply side, that means the availability of services and the supplies of these services, but also on the demand side, how people access it and used them. And you can see on this slide, the ones in dark blue are the ones that are affected by the demand or the use of the services. And in fact, they're quite prominent in the reasons for service disruption. So most obvious were that staff were not so available. They were deployed for COVID response, and that is by far the biggest reason why services were disrupted. But then in second place, community fear or mistrust of certain healthcare, a decrease of outpatient volume. So then a second place, third place, these access to service issues very much came to the forefront as people feared interacting with the health system, at least initially. Next slide, please. Seeing these disruptions and these results, actually WHO came up with a set of recommendations, and these recommendations were both on the system side and then on a specific program side. On the system side, of course, we needed to take into consideration the context of the changing environment and needs, the adjustment of the governance and coordinating mechanism, especially also as they relate to financial barriers, the reconsiderations of health workforce. So as the health workforce was refocused on the COVID, we needed additional staff to assist, the optimizing of the health services settings and platforms, and then maintaining the availability of essential medications, equipment, and supplies. In the program specific, there were also specific recommendations for maternal and newborn health. The recommendation was that all essential elements of antenatal care and postnatal care were to be managed, access to skilled care at all times, and then, of course, the commodities and supplies required for ANC, childbirth and pregnancy services to be available. In the area of health worker safety and patient safety, the highlights were, or the recommendations were, the synergies between health worker safety and patient safety policies, a very important linkage there. A safety culture, high reliability systems and organizations that would ensure a culture of safety. Safe clinical processes such as checklists and guidelines, the engagement of women in this process and the empowerment of women in this process, and then the protection of the health workers, both physical and biological hazards but also the mental health aspects of this engagement. Next slide, please. WHO issued quite a number of resources. You can see there the pulse survey results being released, and that's of course the second one. The Maintaining Essential Health Services Operational Guideline, the use of data in terms of the essential health services in COVID, and then on the patient safety side, the Patient Safety Action Plan, the Charter, the goals that we talked about a minute ago, infection and prevention guidelines in primary health care, and as was mentioned earlier by Ian, the first module of a new training package on IPC. And if we can go to the next slide, you can see the next slide, please. So in fact, this is being launched today in a different venue, but very closely linked to what we're doing here. The strengthening of infection prevention and control in primary health care, very, very important, of course, for the safety of the individual patient and indeed the health worker. And the first module here related to exactly the topic we're talking about, that infection and prevention and control in maternal and neonatal care. Next slide, please. So at the end of my presentation, just a summary of the key messages. We all know that the disruption of essential health services was quite evident in the COVID outbreak. These disruptions spanned across the major health areas, including very much the maternal and newborn services. We saw disruptions caused both by demand and supply side, but with time there was actually an improvement. The system was actually able to mitigate that impact and become better as the pandemic went on. A systems approach was needed to address the issues of disruption, both broader system interventions, but then also specific interventions, both at the maternal, newborn, and health and safety side, but also on the health worker safety and patient safety side. Very important is, of course, the context consideration. The context, think about the geographic context, the continental context, Africa being quite different, I think, to Europe or other maybe developed areas in terms of the context in which this pandemic spread. The risk for mothers and newborns of adverse outcomes were associated with unattended childbirth, and these risks sometimes outweighed the potential risk of the COVID transmission in health facility. So a very clear message that in spite of the COVID, the ongoing services were truly, truly important. Next slide. So at the end of this, as has been said before, this day is now to remind us to act now for safe and respectful childbirth. And this is very much true also in the context of the COVID response. Thank you, Sir Liam. Back to you.
Thank you very much, Rudi. And I think shows the power there of gathering important real-time data and being able to assess in the way that WHO can the global position on the way that health services are functioning and recovering and have been damaged during the course of the COVID-19 epidemic. So thank you pandemic rather. Thank you very, very much for that, Rudi. You've heard all of the regional directors were very keen to make their contribution today. You've heard from some of them already. We're now going to get a message from Dr. Hans Kluge of Europe, the regional director, WHO Euro.
It is my honor to address you on this special day. This topic should be close to all of us, not only because we all have been or will be patients of some kind, but because ensuring that patients receive the safest and highest quality of care is at the heart of our efforts to achieve universal health coverage. Patient safety is central to creating robust and resilient health systems where all people, regardless of background or socioeconomic status, can expect to receive safe and humane high-quality care. This year's theme shows that patient safety is an area that covers the entire life cycle, starting with newborns and young mothers. In the WHO European region, we have made significant progress in recent years, with the maternal mortality rate having decreased by almost half between 2000 and 2015. But the numbers are still too high, and the deaths that still occur are for the part mostly avoidable. We need to act now, and there are 3 ways we can make a difference. First, we need to up our investments in health systems. Mothers and newborns need access to a range of quality postnatal services in hospitals, primary healthcare centers, and at home. Ensuring access isn't easy, but it can only come if we put the resources and the workforce where they are most needed. We know what needs to be done. We need to focus now on the how. Second, we need to refocus our attention on building a competent and resilient health workforce. We know that a qualified and trained doctor, midwife, or nurse can make the difference between life and death. But we need to make these professions attractive to young people entering the workforce, especially now in COVID-19 times. And this can only come with investment in the education and professional development of all health workers, and appreciate them. Finally, and third, our European Programme of Work, EPW, provides a crucial opportunity for member states to listen to the needs of almost 1 billion people across the region and act for their health and well-being. The EPW calls for partnerships across key sectors in society, which also includes patient organizations advocating for better quality of care. Let's act now in partnership and solidarity for the safety of mothers and newborns everywhere.
Thank you very much, Hans, WHO Director for the European region. And finally, we're going to hear from Dr. Jonás García. He's a very long-standing member of the patient safety community, now a senior advisor in the PAHO regional office. Jonás, over to you.
Buenas tardes, buenos días a todas y todos.
Good afternoon, good morning to everyone.
We are celebrating this day in the Americas with the optimistic vision of safer care for all of us, and especially for the mother and the newborn, leaving no one behind. The reason for our optimistic vision is that we see so many efforts and stakeholders getting together: patients, healthcare workers, experts, health authorities, public health schools, international organizations. Access to quality health care is understood as a right, and equity and solidarity is behind and driving all those efforts. A positive and mutual reinforcing movement with healthcare workers, quality projects, groups working on public health functions, today are discussing patient safety as a global public priority. We need to build on all those efforts, and it's clear for us that the Global Patient Safety Plan 2020-2030 is a clear roadmap to move forward. Today is kind of difficult to cope with so many activities going on, but we feel this is really an opportunity, and we really want to share and to invite you to see and to know what's going on the countries of the Americas. Thank you.
Thank you, Jonás. And that concludes our overview of the global landscape and all of WHO's initiatives on maternal and newborn health and safety. In view of the need to keep to time with the different time zones, some of which are quite late in the evening, we're going to move through the planned 10-minute break straight on to session 2, which is the theme of which is prioritizing maternal and newborn safety in the context of universal health coverage. You heard Dr. Kluge mentioning universal health coverage. It's a really important priority and a really important context for today's World Patient Safety Day. So I'd like to hand back to Neelam, who's going to lead us through this second session.
Thank you, Sir Liam. Really appreciate your leadership in walking us through the global initiatives and landscape of maternal and newborn initiatives. So in this session on prioritizing maternal and newborn safety in the context of UHC, it's actually a 2.5-hour session. We'll hear stories from the ground, economics of patient safety, and also the NHS England journey to reduce maternal harm. And we have 2 panel discussions, first chaired by Sir Liam and second by Ms. Helga Fogstad, Executive Director of Partnership of Maternal and Newborn and Child Health. So first speaker is from Pakistan, and her name is Neha Mankani. She's a community midwife and a senior manager, midwifery and director of Mama Baby Fund. Her presentation is on stories from the ground, provision of safe, respectful maternity care through midwives in Pakistan. Neha, thank you so much for joining us. The floor is yours.
Thank you very much. Good afternoon, everyone. I'm a midwife based in Pakistan. And as part of my work on the ground, I manage teams of midwives working at midwife-led birthing units in rural parts of the country. So today on World Patient Safety Day, I'd like to share how an intervention around safe and respectful childbirth changed the maternal health landscape of an entire community that I worked in. So in 2018, I visited this rural village called Bhong. It's located in South Punjab. Hello. And to evaluate the maternal and neonatal health challenges the community was facing. So I was there because we aimed to develop an intervention at a facility that had a primary care setup and it had urgent care services. So I was told that the women in this community are very reliant on traditional birth attendants, untrained attendants, and that any maternal health services offered to them have very low uptake. But I knew that there had to be more to the picture than that. So I did this 2-day assessment of the community. And in those 2 days, I saw cases that I hope that no one has to see in their lifetime. There were a number of asphyxiated babies. They were born at home with large amounts of oxytocin given to their mothers. There were women who came into the AR completely septic after unsterile and most likely unnecessary C-sections at local providers' clinics. I saw a ruptured uterus after a woman was guaranteed a safe home birth after a C-section. I saw a mother who came into urgent care with an intrauterine death, and she said she had run away from the government hospital while in labor because she had been in labor for 24 hours and no one had monitored her baby, and a doctor had hit her for being too loud in labor. So the solution, as I saw it, for the catastrophic maternal and neonatal health challenges this community was facing had to be community-based, in my opinion, and they had to be based in a model that put women first. And we knew from speaking to women and families that their challenges were multi-pronged. The adverse outcomes they were facing, this unsafe care was because of their lack of access to quality care, but it was also because of the disrespect and abuse they were experiencing at facilities. This was a larger barrier to them than cost of care or distance from facilities. And this is something that data around disrespect and abuse in childbirth has shown us globally. So women told us that they knew birthing at home with unskilled support was unsafe, but they chose it over the treatment that they were receiving at birthing facilities. So now I was armed with knowledge of these barriers, and we started one of Pakistan's first completely midwife-led birthing units in this village. So the community midwives that run this midwife unit, they belong to the area, they spoke local languages, they understood community customs and practices. And when I train midwives, I always start by helping them understand how a midwife literally translates into with woman. So a midwife is a woman's birthing partner. There's no power structure in this relationship. So we train them on technical skills, but a large part of our work was helping them identify respectful practices and how it impacted the quality of their work. So in some instances, this was as simple as letting women birth in positions of their choice, help them make informed decisions around their birth, and ensuring comfort, dignified care with a support person of their choice. So this resistance that I had been told about to skilled care was very short-lived. In the first month of services, we saw maybe 20 women in our antenatal clinic. In the second month, we saw 300 women in our antenatal clinic. So the women who everyone had told us were wed to unsafe births in their homes started pouring into our facility. The first woman who delivered at our facility had come in for her 9th birth. She had lost 4 out of 8 of those babies. And it was the first time she had chosen to access skilled care because she had heard people would treat her well here. So 3 years and 800 births later, we scaled up this low-cost, high-quality solution to 7 other sites, and our midwives are now providing care through our network in rural villages, at a boat clinic in the middle of the Indus River, and at an island in the middle of the Arabian Sea. So the common practice in all of this is respectful, client-centered care. So in closing, I would just like to say that we know now that midwifery care is an acceptable and scalable model of quality maternal and neonatal healthcare, but it does operate within a system. And for it to be effective, it also needs health system support and an enabling environment for midwives. So that includes respectful maternity care at referral sites as well, and system level monitoring and regulation. Thank you.
Thank you, Neha, for sharing your ground experience and how you've been managing and providing care at the front end. Next presentation is on the economics of patient safety in the workplace. And I have the pleasure to introduce Dr. Kluge from OECD. He's heading the OECD Healthcare Quality Indicators Program. OECD actually has launched several series of economics of patient safety documents, and today also they have launched new reports on patient safety. So Neek, we'd like to hear from you. The floor is yours.
Thank you, Neelam, and thank you for asking the Organization for Economic Cooperation and Development to participate in this meeting. Next. I think the order of the slides is slightly different than I provided them, but I'd like to speak about the link between safety and economics. As might be clear, the role of the Organization of Economic Development is to support member states in economic development. And the story that we try to do, and the story we try to tell, is that patient safety is not just a public health issue, it's also an economic issue. Is it possible for me to get my first slide, please? Backward. I'll do what I hope to show was the slides that lists the various reports that have been produced over time. As you said, Neelam, the OECD is collecting statistics on the economics of patient safety since 2017, and we produced a series of reports for the Global Safety Summit and for the G20. Actually, 4 of those reports were commissioned by the German Ministry of Health, and I'm very happy that today we are in the position to launch a new report on the safety of the workplace. Actually, that is linked to the theme of last year. And although, of course, midwives and delivery is a similar topic, my intervention is mainly to tell you a little bit about the importance of this report. Basically, and I saw that slide was available, the importance of focusing on the safety of the workforce is linked to the problems that are also occurring during the COVID crisis. Could you try to find that slide for me, please? No, it doesn't seem to be there. Anyway, why we picked up the work of looking at the importance of the safety of healthcare workers is that healthcare workers are substantially affected by the pandemic, not just by infections, but also by the mental impact it has. So that's why, looking at what needs to be done, we produce a report where we show the economic impacts of not putting sufficient emphasis on safety of healthcare workers, showing what the costs are of occupational harm, and overall building an economic story that if you don't invest in the healthcare workers, the safety issue will stay as big as it is now, and the failure costs of safety will overall in industrialized countries like the countries of the OECD link up to 13%. How to address this? Well, actually, that's what the previous slide shows. The report addresses 4 ways of dealing with the safety of healthcare workers. The first one, to focus on culture and the working conditions. Safety culture is an essential part. The second is to really empower healthcare workers to be able to be resilient. There's a lot of talk about the resilience of healthcare systems, but the foundation of that is the resilience of the healthcare workers, being in a position to be adapting to changing needs. Of course, processes need to be standardized and evidence-based, but at the same time, people and the workforce should be flexible enough to address the challenges that are posed by a pandemic. Also, we see that a lot of the safety work has not aligned yet the risk management approach for clinical care, the safety of the healthcare worker, and the safety from the perspective of the corporate organization. So the suggestion of the report is really to advise member states to include measures of worker safety in the overall approach towards patient safety. The next please. So it is a plea for investing in healthcare workers and in their well-being. And the report shows how that could be done. First, by an increased need for flexibilization of the workforce. A substantial part of the people working in economies is now working in healthcare. There are shortages. And today in the OECD member states, there is a big tension between the availability and the potential of people to fulfill all the roles that are there. So flexibility of the workforce is one. Concrete policy actions to support workers, not just during the pandemic with protective material, testing capacity, and vaccination, but also the overall psychological support to carry on, to deploy change as part of incentivizing people to really adapt to changes that are posed. And last but not least, to consider worker safety, not as just preventing harm, but overall as promoting the well-being. So if investments are made now in the aftermath of the pandemic and restoring economies, I hope the report makes a very good case for people to address patient safety, not just as a public health problem, but as a major problem to keep the economies healthy. Next one. So thank you for the opportunity. I hope people will be able to have a look at the report, which will also be launched today in Berlin at the meeting on patient safety, which is held there. And from the OECD, I'm really looking forward working with the World Health Organization to further implement the action plan for the coming decade. Thank you.
Thank you very much, Neha, for joining us today, and apologies for any mix-up on the slides. But I must mention that the series of economics for patient safety reports, which have been produced by OECD in collaboration with the German government, have been extremely helpful in building the case for patient safety globally, whether it is safety in hospitals on the primary care, or it's related to analysis to action, long-term care. All these reports are absolutely vital in this effort. So really appreciate your leadership in developing this series of reports on economics of patient safety, and the series continues today as well. So congratulations to you. Thank you. Next, we have a video message from Mr. William Vinal, who's the Director of NHS Quality, Safety and Investigations at the Department of Health and Social Care in England, UK. His speech will focus on progress made by the UK government to halve the 2010 rates of stillbirths, neonatal and maternal deaths, and brain injuries in babies by 2025. Could we have the video, please?
Good morning, everybody. My name's William Vinal, and I am Director of Quality, Patient Safety and Maternity at the Department of Health and Social Care. I'm giving this address on behalf of our Minister, who is unable to attend today due to a government reshuffle. And I just wanted to start by saying that the commitment of the Department of Health and our ministers to the cause of patient safety domestically and globally remains undiminished. And I'm very delighted, therefore, to be speaking to you on World Patient Safety Day. And before making my remarks, I'd like to pay tribute to two people who have been such great advocates for the vital cause of patient safety. First of all, Dr. Tedros for his invaluable contribution to patient safety, as well as guiding the international response to the COVID-19 global pandemic. And secondly, to Jeremy Hunt for his continued commitment to improving patient safety, both in the United Kingdom and around the world. Obviously, COVID-19 is a deadly disease which has attacked societies, economies, and health systems all across the world. And it has also put unprecedented attention on the issue of patient safety. This year's theme for World Patient Safety Day is safe maternal and newborn care. The government is mindful of the global situation. It's estimated that every day around the world, nearly 5,400 stillbirths occur, and that 810 women and 6,700 newborns lose their lives. We know that the majority of these tragedies could have been averted. Quality of care is fundamental here, and respect is central to this. We therefore stand with the World Health Organization in raising our voice for more awareness and the need to step up collective global efforts to provide respectful and safe maternity care. There's nothing more distressing than knowing that the death or injury of a loved one or friend could have been prevented. We all have an interest in getting this right. And this World Patient Safety Day provides a vital opportunity to tackle the critical issue of providing safe care to pregnant women and their babies. Here in the UK, we've made good progress in our mission to improve outcomes since we launched our national maternity safety ambition, which is to halve the 2010 rates of stillbirths, neonatal and maternal deaths, and brain injuries in babies by 2025. We've seen a 25% reduction in the stillbirth rate since 2010, and a 29% reduction in the neonatal mortality rate for babies born over the 24-week gestational age of viability. It means that there are now at least 750 fewer stillbirths each year, and hundreds more mothers and families going home with a live, healthy baby each year, which has brought joy to so many people. I'd like to pay tribute to all the maternity and neonatal staff working in the NHS and across the world for their hard work to support women, babies and partners, especially during the pandemic. But there's no room for complacency when we know that unacceptable variations in the quality of care and outcomes still remain. For example, Black, Asian and minority ethnic women can face specific issues in accessing services and are more than 4 times more likely to die from complications in pregnancy than their white counterparts in the UK. And this will be something that our new Office for Health Improvement and Disparities here in the Department of Health will be looking at very closely. We're also determined on the domestic front to make improvements in patient safety more broadly. In 2018, we appointed our first National Director for Patient Safety, Dr. Aidan Fowler, and under Aidan's leadership, our National Health Service published a 10-year NHS patient safety strategy with substantial programmes that are planned and underway. This includes a framework for involving patients in their own safety and a patient safety syllabus and training for all staff within the National Health Service. But just as we work to tackle patient safety here at home, we've also got to look outwards and globally. Patient safety is of course a challenge for everyone all across the world, and the pandemic has laid bare the interconnectedness of the modern world and how healthcare is clearly not solely a domestic affair. And going back to today's theme, we also know that maternity care is affected by broader global issues like gender equity and violence and trauma inflicted during childbirth. So we'll keep working with other member states to reduce harm to patients worldwide. I'm proud that the United Kingdom has been flying the flag for global patient safety and driving forward this important agenda. Together with Germany, we established the annual Global Ministerial Summits on Patient Safety, which I attended. We also established a Global Patient Safety Collaborative, which is being implemented by the World Health Organization and Imperial College London, to stimulate patient safety improvement in low and middle income countries. And we co-led with Kenya at the World Health Assembly Resolution of 2019 on patient safety, which gave us an annual World Patient Safety Day, which we're marking here now. The resolution recognised patient safety as a key global health priority and is spurring countries to reduce the scale of their problem through uptake of its recommendations. The resolution also requested that the WHO should formulate a global patient safety action plan, which I'm delighted was launched last month. Along with the resolution, the action plan is another step forward in the global mission for patient safety, setting out concrete actions that any country can take to eliminate avoidable harm in healthcare. So in conclusion, I hope that you find today's event valuable, and it's great to see so many countries represented today. I hope that it sparks ideas and actions in health services in all four corners of the globe, so we can make this world a healthier and safer place. Thank you very much.
Thank you, William. I really appreciate you could join us even through a video message at a very short notice in this transition time. Really appreciate that. So moving on, now we would like to hear from you. All of you have a poll question. In your point of view, what are the priorities for establishing safer maternal and newborn services in countries? Please participate in the poll by clicking the link pasted in the chat. This will navigate you to a browser window through which you can enter 3 responses. The question is, in your opinion, what are the priorities for establishing safer maternal and newborn services in countries? And the options are political commitment and financial resources, collaboration and stakeholder engagement, infrastructure, essential supplies, and safe working environment, women, family, and community engagement, skilled healthcare workers, and safety culture. Please just click your 3 options, and please note that these are automatically submitted. So over to you for the poll for a couple of seconds. It's absolutely amazing to see the responses coming. And I think what it shows is that actually all these are the priorities which are required for establishing safer maternal and newborn services in countries. However, if you see political leader commitment and financial resources, skilled health workers and infrastructure are coming out to be topmost priority in this poll. So with that, I would like to thank you for taking part in this poll, and we move ahead to the next part of the program, and in which I would be actually handing over to Sir Liam Donaldson to chair the panel discussion on what should countries do to prioritize safety agenda in maternal and newborn care. Over to you, Sir Liam. Thank you very much.
Thank you very much indeed, Neelam. We're going to hear very briefly from each of the panel members in a moment, but before we do that, and then obviously at the end, we'll take questions from those of you who are on the line and put them to panel members. But before we start with the panel members' contributions, I'd like to ask Evangelina Vasquez-Curiel, who is the WHO Patients for Patient Safety champion from Mexico, to share her story about the provision of maternal and newborn care. And Evangelina has been involved in the Patients for Patient Safety program for many years, and she's a very active patient safety advocate in Latin America. So Evangelina, over to you.
Sí, buenos días. No sé si
Yes.
puedan prender mi cámara.
Hello. Can I have my camera turned on? I am Evangelina Vasquez-Curiel. I'm a mother, and with my story, I call upon all of you to please start acting for a respectful and safe delivery. When I was pregnant, I told my healthcare professionals many times that my blood type is A negative and not A positive, as they wrote out on my chart, on my file at the end of my pregnancy, and I went to the hospital. I was seen by a young person, not my GYN. She checked me up and she said I had 2 centimeters dilation only, and that I had to go out and walk. And so I walked for hours and came back for checkups. And I kept reminding them that my blood type is A negative. I did so all the time. I saw my GYN on an alley and I asked for help. he told me that if I was stubborn, I would do worse. I reached 4 centimeter dilation, but then later it came down to 2 again. Finally, a physician told me I had to be taken home after 2 days in pain, terrible pain. So I just went to a nearby clinic and they told me that I had to undergo an emergency C-section because of baby stress. My baby was yellow with spots. I took it to a children's hospital and they told me that he had hyperbilirubinemia with incompatibility to my HR and there was stress. And I was right about my blood type. They did a blood transfusion and went through radiation and with oxygen. I slept in the waiting rooms because I was told my baby was in a critical condition. When he became better, he was taken to the nursery. I was told that he was going to have a transfusion because he had anemia and he would receive parenteral nutrition. The doctor, without changing his gloves, introduced catheters to several babies, including mine. Later, I observed that the baby's diagnoses were changed to sepsis and they were dying. It was an in-hospital infection. They told me that my baby just had a very bad flu. I spent many days in anxiety. All mothers gathered and cried together. All babies suffered sepsis. They were all critical. The main outcome of these adverse events for my baby is irreversible and preventable brain injury. So I beg you, listen to the mothers. Care for us with dignity and respect. Thank you so much for listening.
Well, thank you, Evangelina, for that very harrowing story. And you know from the excellent work that you and the other WHO Patients for Patient Safety champions have been doing over the last decade or more that your story isn't unique. And it is a cautionary tale on how we're still slow to learn from one patient's experience in order to prevent harm to future patients. So thank you for sharing your story, a very valuable lesson for us all. Thank you. I'm going to ask now the first of the panel members, to make their contribution. And we have as first speaker, the Honorable Dr. Zulfiya Abdusamad, who's Deputy Minister of Health and Social Protection in Tajikistan, and going to speak from a policymaker's point of view and speaking in Russian.
Yeah. Тех людей, которые делают. Thank you very much, my dear colleagues, dear participants of this conference, which is online. I would like to express my gratitude to WHO for the comprehensive help and assistance to the Republic of Tajikistan. I am especially grateful to Mr. Varshatsky for his support in achieving sustainable development and reduction in maternal and newborn mortality in this very difficult time for all of us. And improvement of the indicators of the health of mothers and newborns is closely connected to the cooperation with the headquarters of WHO, and we work on several programs which include constant education and feedback, which is today a priority for today's meeting. On this basis, we have issued an order regarding the prevention of the infection of community diseases. Understanding the threat posed by infection to pregnant women and newborns, we witness at least 12 to 17% of patients admitted to hospital every year who acquire some form of health care associated infection in low and middle income countries, making infection associated with provision of health. Our head of state underlined that the health of mothers and newborn is in the focus of attention of our government. Dear colleagues, we every year registered about 200,000 births, but despite the decline in the mortality among the mothers, we still face a lot of problems and issues. There is a risk of medical errors which could be prevented by very simple measures like sanitation, hygiene of hand hygiene is one of the most important methods of infection prevention, and even it is not always available at the point of care. But without multifaceted approaches such as lifelong learning, behavior change, and feedback, this is difficult to achieve. This problem with water supply and professional protection will help to reduce the maternal mortality. Patient safety is one of the most global priorities, and the Republic of Tajikistan, along with all countries of the world, celebrates this day every year and implements this initiative in the form of various campaigns and seminars. In general, medical hygiene compliance varies. For example, according to the World Health Organization, it ranges from 5% to 89%. We have excellent doctors and midwives who work in our maternity hospitals and clinics who have thousands of birth surgeries and observations of pregnant women behind their backs. Not in all maternal houses we observe strict sanitary rules, and taking into account the peculiarity of this problem, and our technical group works on the developing technical standards regarding safety of our health workers. COVID has influenced so many aspects of our lives. Many women come with our symptoms, and it's very important for them to get tested safely. And this pandemic told us that we have to observe all the rules of well-being. Waiting for the birth of a baby is the most joyful and at the same time anxious period for a moment. Thank you for your attention.
Thank you, Dr. Zoldia, for telling us about the actions that you have in place in your country, which is very helpful in giving us quite a deep insight into what can be achieved at Ministry of Health level. I'm turned now to the next panel member, Professor James Walker. Professor Walker was a past professor of obstetrics and gynecology at the University of Leeds in the United Kingdom, but his work today features on his role as clinical director at maternity investigations in the healthcare safety investigation branch. For those of you who are not aware, the healthcare safety investigation branch is a rather novel organisation that was set up in the UK's National Health Service in order to carry out the depth and quality of investigations of patient safety incidents to the level and standard that it would be carried out in other high-risk industries, such as the airline industry. So some of their investigations have already entered the public domain and provided, I think, a much, much deeper insight than we would normally see in our routine incident reporting systems into the causes of harm in healthcare, and particularly today featuring on those investigations in the field of maternal and newborn care. So over to Professor Walker.
Thank you very much, and thank you for inviting me to be involved in this very important day. Under the direction of the then Secretary of State for Health, Jeremy Hunt, the maternity investigation program commenced in April 2018 and has carried out over 1,700 investigations into maternity and safety incidents since then. I am the clinical director and have been responsible for setting up and developing the program. We carry out independent investigations into why incidents occur and where there are find weaknesses in the system that allow these to occur. By learning from these investigations, we make recommendations to implement change and prevent recurrence of this and similar incidents. This helps to build a culture of safety that involves professionals, organizations, and families. There's no assertion of individual blame, as it is the system that allows the errors to be made. And removal of the individual does not remove the flaws in the system that allow the error to take place in the first place. Our program aim of our program is to increase the insight of healthcare workers about the importance of patient safety, improve the involvement of families, staff, and partners in the investigations, and recommend interventions that provide improvement with effective and sustainable change in the most important areas. After each investigation, we feed back the findings to the families and the hospital with learning recommendations. We also share these findings nationally with all maternity hospitals and the national bodies, highlighting the areas of weakness in our maternity care pathways and where improvements of training and guidelines can help into reducing the patient risk. After 2 full years of implementation of this program, we are now seeing increased learning in maternity care, increased involvement of the maternity care workers in patient safety, and a reduction overall in the number of cases that are occurring. Thank you.
Thank you very much, James. And from one obstetrician to another, Professor Shahida Sheikh, Head of Department of Obstetrics and Gynecology at the Chandka Medical College in Sindh in Pakistan. Over to you, please. Wondering if we have problems with the connection to Professor Sheikh. We're not seeing any signals or anything, so I think we'll move on to the next panel member. Okay. Yeah.
I can hear you.
Okay, please carry on. We couldn't hear you to begin with.
Oh, sorry.
Thank you, Sir Liam. It's an honor speaking to you, and thank you, WHO, for inviting me on this very special day of Patient Safety Day. I'm working in a city, in a hospital, which is 500 kilometers away from the capital of the province, Sin, and we are receiving the patients from the poor, poverty-riddled areas. The patients are infested with the lawlessness. They are entangled with the taboos of their tribal culture. So we have the broken antenatal system even. So we are receiving the patients very advanced stages, like they are having the hemoglobin of just 2.5 grams and 3 grams and 4 grams. So even after pandemic of the COVID, the safest second pregnancy, which is considered itself as that becomes very serious state. So patients are coming with severe preeclampsia. There is unusual rise in preeclampsia and eclampsia. So patients are just dying in our hands. But this is one side of the story, but another side is that we had many babies were dying just from the dying from the preventable causes. So I'm grateful to the WHO AMRO region, the country office and SIN office of the WHO. They started initiative of the early essential newborn care with just doable and very cost-effective methods with the 4 variables of rigorous trying, delete cord clamping, breastfeeding, and then like this. So we started with early essential newborn care. Initially, we had the coaches arranged by the senior coaches arranged by the WHO. They traveled hard to Larkana and the far-flung area where they started coaching. So now we are in the rollout positions. So we have so many master trainers and so many the junior persons who are coached, who are trained in early essential newborn care. So we are maintaining the data on those babies. We had to practice the early essential newborn care. So literally, I feel very happy when we are working on this, when we are intensively following the babies on we are calling them on the 7th day and 28th day, we are collecting our data. So people have started trusting us. Initially, the doctors were unnecessary blame with the willful misconducts. They were unnecessary or sued in so many legal things. So ENC has brought so many changes. People have started trusting the public sector hospital. I'm working in urbanized public sector hospital, tertiary care hospitals. So all the patients are coming with a serious state. They are just coming with a mind that they will be having cesarean section, but with the patient's care, with the extraordinary vigilance and the surveillance of the mother, then we are asking them for having the normal deliveries, and when we are practicing the early essential newborn care. So the results are coming up. So we are now scaling up towards the primary healthcare and secondary healthcare. Although we have a lot of resistance, we have a lot of no-go areas. System is not that much supportive, but with my team, with my colleagues, I have prepared my colleagues. So I have been to other universities apart from my university, but I'm going now scaling up the training to the primary healthcare workers, and secondly, where we have the untrained birth attendants, the midwives and ayahs maybe of 60 years, 70 years, they're working since long, 30 years, 40 years. So things must be changed. They must be knowing about the respectful childbirth, how the companions should be given the priority. Although we are not allowing the male partner in our labor room, but what the patients are saying about the companion of choice, we allow them. But the thing is that we have to sensitize our policymakers, our stakeholders. We being academicians, we are trying hard to work for these women, the women who are coming in a very serious state. And so hopefully we are looking for the good things always. I believe always in silver lining. So when we are working in that difficult areas with limited resources, with limited human resources, HR is dirt is there, so janitorial staff is very short. So despite all these difficulties, we are focusing in on the safe childbirth and respectful maternity, and we want to save the babies as well. So with the simple, effective methods, because you see the ventilators and the logistics, they are available, but we don't have the technical stuff. So with just simple methods for variables of the essential newborn care, are expecting so many changes. So we are collecting the data, and we are hopefully publishing in the coming year. So it will be giving the results. Thank you so much.
Thank you, Shahida. We turn next to Professor Lorena Binfa from the Department of Women's and Newborn Health Promotion in the Midwifery School at University of Chile.
Good morning, good evening, and good night. Thank you so much for this invitation. I would like to start saying that Chile is very well recognized for its improvement in maternal and neonatal health. This started in the 1950s with the implementation of strong public policies aimed to increasing professional attention during childbirth. In the 1960s, a very successful family planning program was implemented, giving midwives the main professional responsibility for these activities. In 1994, the Ministry of Health took the decision to transform the traditional maternal health program into the women's health program, accounting for reproductive as well as non-reproductive health activities, incorporating life course and gender perspective. Today, midwives attend almost 90% of the women's health program activities, including antenatal, postpartum, gynecological, and family planning control. A normal birth in the public system, which accounts for almost 80% of the Chilean population. I have to say that the midwifery profession started in Chile in 1834 at the University of Chile. So it's a very long-standing profession. In 2000, to improve health indicators, decrease health inequalities, and provide high-quality services in accordance with the expectations of the population and the scientific evidence, a model of integrated and humanized health services was adopted. In 2007, and to achieve a safe, personalized, and human delivery, a clinical guide for humanized care during delivery was implemented, emphasizing continuous emotional support and avoiding unnecessary interventions. Progress has also been made towards equity and rights with the introduction of the National Policy on Sexual and Reproductive Health, the legislation for the patient's rights and duties, voluntary interruption of pregnancy in 3 special cases, and recently a norm to audit C-sections. Today is under discussion a law accounting for gender violence, including obstetric violence. Despite all this, Chile has one of the highest rates of C-section in the region. A very medicalized midwifery model of care with high rates of obstetric interventions and almost 30% of dissatisfaction, mainly because of mistreatment and disrespect. This, together with an increasing migrant population, especially women in the reproductive age, and the outbreak of the COVID-19 pandemic, have posed further a huge challenge to the health system. A technical orientation guideline for a personalized maternal and neonatal care was started in 2018 and interrupted because of the pandemic demands. Now it has been resumed. In 2020, a national director for midwifery position at the Ministry of Health was placed. Moving forward needs further actions. Among these, increasing midwives' autonomy for leading normal birth, as well as strengthening competencies for obstetric teamwork based on an effective collaboration and a trustful relationship seemed to be very important. Thank you so much.
Thank you very much, Professor Bimfa. And we move finally to Dr. Ranjan Pejawar, who is the president of the National Neonatology Forum of India.
Hello, am I audible?
You are, sir, yes.
The chair of the session, Sir Liam Donaldson, learned members of the panel, members of the panel, the members and leaders of all the organizations here, and more than 800 participants who have logged in for this session. I bring greetings from the National Neonatology Forum of India, which has 10,000 and odd members as its workforce. I would like to remind the people who are here that India is a unique country with an annual birth rate of 27 million, which is as equivalent to adding the continent of Australia every year to India. I have not prepared any slides, but I'm going to speak briefly as I was asked about this. Our neonatal mortality rate is about 21 per 1,000 live births. The institutional deliveries have gone up rapidly in the recent years. It's crossed 80%. However, the antenatal visits, 4 antenatal visits are recommended by the Government of India. The rate is just above 50, that is 52%. So you can understand the perinatal burden, health burden India carries. So what India as a country will do to prioritize safety agenda in maternal and newborn care? Do we have a pediatrician and an obstetrician present at every delivery? The answer is no. And we may not have for several years to come. However, we have started on various programs for the nurses, paramedical workers, and the medical officers manning our SNCU, which is Sick Newborn Care Unit, in districts and sub-district level. We train the nurses in basic resuscitation. We train these workers in basic resuscitation, teach them the essence of first golden minute, the golden hour, and extend the training to include essential newborn care. There are various programs floated by the government and the professional organizations like National Neonatology Forum, Indian Academy of Pediatrics with its 32,000 members, Federation of the Obstetrics Gynecological Societies of India with its 35,000 members are all collaborating. We are fortunate to have the support of the WHO country office, UNICEF country office, the various non-governmental agencies like USAID and others, and with the government as our leader, we are doing this very vigorously. Needless to say, the COVID threw a spanner in the works, but we are slowly coming out of it, but we have lost some precious time because India has imposed it on itself the arduous goals and task of achieving a single-digit NMR by 2030. So this is about the first point. The second, so that includes the collaboration, which is very, very important to achieve this. The second is, what are we going to do for safe delivery and safe newborn care? The mantra would be, again, cost-effective interventions, i.e. the antenatal steroids, the magnesium sulfate as neuroprotection for preterm babies, antenatal magnesium sulfate, deferred cord clamping, optimum use of oxygen in resuscitation, the skin-to-skin care right from the time of birth, that is delivering the baby onto the abdomen of the mother. This needs a little bit of improvement as far as implementation is concerned. And then early breastfeeding and exclusive breastfeeding. I must say the pictures are not very pretty currently. The rate of early breastfeeding is 45% and exclusive 6 months breastfeeding is about 55%. Even this needs some vigorous work to be done and health education to be imparted. Then comes the question of the health system in India. There is a large chunk of healthcare being provided by the private sector, the corporate sector. So we have to hold hands and follow the model of private-public partnership, which is again done through these professional bodies. So we have improved on institutional deliveries, trying to have a skilled person, not necessarily a qualified pediatrician or obstetrician, but a trained person, one to look after the mother, one to look after the newborn in these institutions. And we have collaboration. We are aiming to rely on cost-effective interventions. So there again comes the collaboration between the obstetricians, pediatricians and other specialists, which through various programs of these professional bodies, we are bringing them closer and closer together. The important aspect of communication and communication has to be addressed. So all this training involves communicational skills to talk to the parents, to involve the parents in the care, to inform them in their state of high sensitivity, fear, and nervousness. They have been taught how to talk to them and give them the respect due and guide them and be by their sides. As far as a birth companion being present at the delivery, that practice has just begun, mainly in the urban and suburban centers, semi-urban centers, but I don't think it has percolated into the rural area. But however, in the rural area, a lot of parents volunteer and be a part of the healthcare plan in the hospitals. The other thing which finally we are going to do is the involvement of state. When I mean state, it is province, in all the programs which have come from the central government. So it will be disseminated all over the country. As you know, we have 15 recognized languages and 200 dialects. So it's not an easy task, even the health education. But we are on the way of strengthening the health education and catering to all the various provinces which speak different languages.
Thank you very much, Professor.
The final thing is about resuscitation. We are going about it in a very systematic way, and we hope that in the years to come, we will be able to provide evidence-based, low-cost, respectful and safe care to our mothers and newborns. Thank you.
Thank you very much indeed, Professor Pejavar. Could I put a couple of questions to the panel now, because we are quite tight for time, but those were very interesting presentations. Thank you. Maybe I could start off, direct this one to you, James Walker. The excellent work that your organization does on investigation, in-depth investigation, looking at the human factors amongst others, which is something that isn't always done in healthcare as it is in other industries. But given that the evidence base for best practice in this whole field of maternal and newborn care is quite strong, what do you think the process of investigation of incidents adds? Is it that it identifies failure to comply with best practice, gives very local granular context which the individual unit or hospital can act on, or does it reveal new generic themes that are not necessarily contained within the body of knowledge gathered through conventional research?
Thank you for that question. I think it probably answers all three these areas. I think that, first of all, we can look to see how the systems are set up that work very well as long as things that happen are expected, but don't necessarily adapt to problems when they occur in the unexpected. So we can guide people about thinking about safety of what might happen, and it's important all the time rather than waiting for something to happen. So it's preparation and risk assessment. Also, we can do the granular level at hospital level, they may have a particular problem about where their resuscitators are set, where their staffing is, how they approach their various risk or triage services. So there may be individual situations in given hospitals. But moreover, I think we're probably finding what you hinted at initially is the importance of the interactions of staff and the civility involved in practice. Is how people talk to each other. It's how the quality of care that should be provided to everybody. So it's these factors which we're highlighting, which people have always known about, but we're giving people the evidence that it's present and with ideas of how to improve it.
So you're, just one more question following up on that. You're an experienced practitioner and leading a high quality service in your old job, just as your colleagues on the panel are. How much have you learned that you didn't know before through becoming an investigator? About, if you went back now to running a service, what would you do differently that you didn't do before?
I think the biggest difference now is that you see the number of cases which help of a given type of incident, which allows you to learn from it. In our own experience, we may only see it once or twice. Whereas if we look at for instance, problems of interpartum stillbirth, we've just published a national learning report on that, is that we can look at a number of cases together and look at the common themes. So it's things which we wouldn't necessarily be able to pick up in practice. We know there's something wrong. We have an idea of what might improve it. But until you see the group of things together, that you won't necessarily understand what needs to be done. And that's where, if you were then in practice now, if I was in practice now going back, then you would make sure that you would have some of the safety nets in place, which you know are necessary, which in general day-to-day practice are not required because nothing happens, but it's having things in place in case they occur and be ready for them.
Okay, thank you. And Professor Pejavar, you gave a nice list of interventions for the newborn safety. And it reminded me, I'm sure you're aware from general knowledge of patient safety of Professor Peter Pronovost's bundle of care that he introduced for reducing catheter-associated bloodstream infections in intensive care units and reduced mortality by about 60% in the state of Michigan. But whenever people tried to bring those interventions to other places, initially they didn't succeed. And it was discovered that they didn't succeed because the organizational development and the cultural change wasn't being done as well. Whereas in his original work in Michigan, they did the interventions, but they also engaged the staff and got everybody focused on what needed to happen. So I think that led to a greater appreciation that there is a difference between interventions and the implementation of the interventions. So I just wondered, if you go back over those interventions, have you found them easy to implement, or have you found that the take-up or the adoption of the evidence-based practice is very variable?
Thank you, sir. You rightly said that the interventions which are proposed, advised, take a long time to take off and become a day-to-day practice or routine practice. I shall give you the example of the antenatal steroids. We did a lot of work on that, both the government, the professional bodies, and the developmental agencies. Our current compliance to antenatal steroids to mothers who qualify for that is just 65 to 70%, which is not bad. But India being a large country, there are a lot of infrastructural problems. Like, for example, the steroids may go out of stock in some of the places, both government and in the private. And then there may not be a person who can inject the steroid to the patients who come to the antenatal clinic, when they have risk factor of preterm delivery. So these are the things which do stall or decelerate the take-up of these, like you rightly said, of these interventions. But we have found that by perseverance, as you said, it is improving. Just to give the same example, India's compliance is about 65%, and the global compliance in low and middle income countries is 51%. So we are above the average. So okay. I agree what you have said.
Thank you. Shahida, ask your experience in Pakistan. How have you found the difficulties of getting the adoption of evidence-based best practice? Have you found it, how challenging have you found it? We had a bit of trouble with the connection before, so I think we maybe move on.
Yes.
Yes, go ahead.
There are so many difficulties we are facing, and whenever we are adopting new things, like the Indian counterpart said, the intervention with in the form of this steroids. So when we started using the misoprostol for saving the mothers from the PPH, the people started misusing in the form of inducing the patients for the labor, and that ended up into so many ruptured uterus. So we are sensitizing the people about apprising them how much the dose of the misoprostol should be given in a laboring mother for induction or augmentation. So people, because of the literacy problem, and the area where I am living, the volume of cases is so high. So we don't find that much time to counsel each mother and her companion regarding the things. But those things which are not giving harm to patient, definitely we're practicing those. So we are like in early essential newborn care, we were sometimes getting out of stock for the baby's cap. So we were not having the enough time to change for the second pair, wear the second pair of the glove. And even the sanitizers were out of stocks. So we started working on our own. We collected the funds, some philanthropists they donated towards the hospitals. So we have started to pile up the things in our own stores. Even the medical director is not very helpful because the audit is the problem in our hospital. So people are not willing to work so 24/7 in the field of, especially in obstetrics, where as I told you, the doctors are always blamed for the willful misconduct, and they are being dragged, they are being trolled on the social media. So many people are even getting out of the field of obstetrics. So, but we are seeing so many new generation, people in the new generation who are very sincerely working. I have met my clinical teams. So I always believe in apprising the people. There will be some fruit out of it. So I keep doing meeting with my stakeholders, my vice chancellor, the medical directors, the other pupils. So then the things get into the system, but there are difficulties.
Okay, thank you. Lorena, you're predominantly working with midwives. Do you find that midwives are they more easily conform or comply with evidence-based interventions than perhaps doctors do?
I don't think so. I think that we have implemented that personalized model for caring during labor and childbirth. And we found after some years of its implementation, maybe 3 or 4 years, that many of the recommendations were not implemented. And the answer, when we talk with them through focus group discussions, is that they didn't receive a good orientation or training. There are lack of resources, for example, for install a proper infrastructure for companionship. So there are a lot of problems that we have to take care of, and of course, staff resistance as well. I think that the younger generation are moving forward because they have been trained in this with competency-based education. And I think that that is a very good point of start, because you need to change from just knowing or have the knowledge and having the skills to have a lot of other skills like effective communication, respect, and what today now it's absolutely impossible to avoid. So I think that we need to get the adequate formation for our health professional. And I really think that it's very necessary to strengthen the collaboration in the obstetric team through effective communication and trustful relationships.
Thank you very much. And then finally, Evangelina, I'll come back to you. Given your tragic experience and your work as a patient safety advocate, if you had a short message for all the professionals, the doctors and the midwives and others working in maternal and newborn care, what would your message be to them?
Sí, yo les diría que trabajen. I would say, please place the patient at the center. Do not forget the hygiene protocols. Listen to the patients and be candid and be generous and work with the patients. Have open communication with them and have uneven communication, that would be my recommendation for them, to be
Thank you very
equal.
much. And I'm sorry we didn't have longer with the panel members, and apologies to the Deputy Minister that I didn't get to her, but we were tight for time. But I'd like to thank all of you for your presentations and also for your participation in a very lively and interesting debate about the issues that you raised and the issues that the launch day has raised. So thank you very much. Just before concluding this session, we have the final two messages from the WHO regional directors, starting with Dr. Poonam Singh, who's the WHO regional director for Southeast Asia.
Good afternoon, Sir Liam Donaldson, WHO Envoy for Patient Safety, distinguished partners, staff from across WHO, and participants. It is a pleasure to join this celebration, the theme of which brings together two of Southeast Asia region's 8 flagship priorities. First, achieving universal health coverage, ensuring access for all to safe, quality, and affordable healthcare services. And second, accelerating reductions in maternal, newborn, and child mortality. On both objectives, the region has, in recent years, made strong progress. Health services coverage in the region is now on an average above 63% as compared with 49% a decade ago. Since 2016, the region has implemented its strategy for patient safety, with most countries developing national patient safety or quality action plans, and several countries implementing administrative structures tasked with ensuring healthcare quality and safety. 4 countries of the region have already achieved the 2030 neonatal mortality rate target of 12 per 1,000 live births or lower. 6 countries have achieved the 2030 stillbirth rate target of 12 per 1,000 total births. 5 countries have a maternal mortality ratio that is below the upper limit of the SDG country target, while 2 more are on track to achieve the target of a 2/3 reduction in MMR since 2010. Institutional deliveries have now reached 70%. In the region and globally, the pandemic has exposed gaps in patient and health workers' safety, highlighting the need for policymakers and facility administrators to strengthen best practices at the point of care to prevent avoidable risks and improve the quality and safety of frontline services, including for maternal and newborn care. This is especially important as countries implement the region's strategic framework for accelerating universal access to sexual and reproductive health, and as they sustain and scale up public investments in health while maximizing the efficiency of allocated funds. On medication errors alone, the world loses an estimated $42 billion annually, excluding lost wages, productivity, or healthcare costs. In low and middle income countries, including in the Southeast Asia region, unsafe and poor quality care leads to $1.4 trillion to $1.6 trillion loss in productivity every year. Inaction is neither affordable nor sustainable, not before COVID-19 and certainly not after. On World Patient Safety Day, WHO reiterates its commitment to support all countries of the region to eliminate avoidable harm in healthcare, to strengthen health service delivery, and to achieve universal health coverage. Because all people everywhere, especially mothers and their newborns, have a right to safe, dignified, and respectful care.
Thank you very much, Dr. Singh. And finally, Dr. Takeshi Kasai, who's the WHO Regional Director for the Western Pacific.
Patient safety is a crucial element in achieving universal health coverage, just as USC is a key part of translating patient safety to the community level. This year's World Patient Safety Day is dedicated to the need to prioritize and address safety in maternal and newborn care, because across the world, women and newborns are exposed to significant risk when receiving unsafe care during childbirth. While it is true that there is no such things as a zero risk or zero human error, we must work towards reducing risk where possible and mitigating impact of errors when they occur. This is especially important in light of COVID-19, which has challenged our health systems and disrupted health services in unprecedented ways. Patient safety is a topic that is relevant to all countries in our region and should be integrated into all areas of healthcare. We are therefore calling for urgent and sustainable actions by all stakeholders to work together to increase patient safety, thereby improving maternal and newborn care, and through this, working to achieve universal health coverage. Throughout the pandemic, we have seen the importance of continuously learning and trying our new tactics to rapidly improve our response. It is vital that this is part of all countries' approach to improve patient safety as a part of our commitment to universal health coverage, because every mother and baby have a right to a positive and safe birthing experience. Please join us on this World Patient Safety Day in promoting patient safety and taking actions to prevent and reduce avoidable harm in healthcare.
Thank you very much, Dr. Kasai. And I'd now like to hand over to the chair of the second panel this afternoon, and that is Helga Fogstad, who is Executive Director for Partnership, Maternal, Newborn and Child Health. And before Helga came to her current position, she was Director of the Department of Global Health Education and Research at the Norwegian Agency for Development and Cooperation. She has over 20 years of experience of working at international level, coordinating this work. So over to you, Helga.
Thank you so much, and very interesting to hear your panel and your session, and that was great. Thank you for that. So, ladies and gentlemen, my name is Helga Fogstad. I'm the Executive Director of the Partnership for Maternal, Newborn and Child Health, which is a global partnership of over 1,000 member organizations that provide a platform for partners to come together and address critical challenges for the health and well-being of women, children, and adolescents across the world. It is therefore, it gives me great pleasure to moderate this panel on World Patient Safety Day. This is the essence of PMNCH, to bring together different constituencies and partners to tackle some of the most pressing challenges for every mother and every newborn. As Right Honorable Helen Clark mentioned earlier today, global rates of maternal and newborn morbidity and mortality remain unacceptably high, and not enough is being done to provide mothers and newborns with high quality, equitable, and dignified care. In essence, this is a matter of basic human rights, including rights to dignity and freedom from discrimination and from forms of ill treatment. It is critical that we recognize and respect a woman's autonomy and prioritize her emotional well-being, choice, and preferences, including the right to have a companion of choice during labor and childbirth. Respect and recognition of women has benefits for the newborn, who also has rights and requires respect and recognition. As WHO's reports, 40% of all stillbirths occur during labor, a loss that could be avoided with improved quality and respectful care during childbirth. Although disrespectful practices exist and have been documented in all settings, COVID-19 has worsened the prevalence of disrespectful and unsafe care further. Emerging evidence from our partners have shown how communities are being affected during the pandemic. Patients and their families have been challenged. Additionally, health workers too face immense challenges. Lack of sufficient human and financial resources and other essential supplies place a huge risk and burden on already stretched health workers. Unfortunately, as we've seen in the pandemic, the basic needs of the workforce are not ensured, especially with regard to access to personal protective equipment and vaccines. This results in lack of morale and burnout within the workforce, all key contributors to providing disrespectful care and unsafe practices. This is why today's panel and dialogue is so critical, bringing together key actors from across various stakeholder groups, such as healthcare professional associations, patients, and civil society to find collaborative solutions to common challenges. In today's panel discussion, we will learn from partners in advancing the safety and respectful care agenda in maternal and newborn health in the context of universal health coverage. So I would like to start by introducing the panel. We have with us Franca Cadet, Dr. Franca Cadet, President of International Confederation of Midwives, Joe Ghiani, founder of Patient Safety Movement Foundation, Jeannie Conry, President-elect of the International Federation of Gynecologists and Obstetricians, Naveen Thakur, President-elect of the International Pediatric Association, Michelle Lacorn, Chief Nurse, International Council of Nurses, and Susanna Leischer, a chair of the International Stillbirths Alliance. And then Sandra I'm going to do this right, Sandra. Mawarania, Advocacy and Program Manager within the White Ribbon Alliance at Kenya. So before approaching the panel, I would like to share with all the participants that our session has two parts. The first will be questions to our esteemed panelists, while the second part will be based on questions to be received live during the conference from you, our global audience. I will address the panelists with the respective questions and give them 1 to 1.5 minutes to respond. As such, may I please encourage you to post your questions either in the Q&A box or in the chat box. So let us get started. I would like to ask each one of our panelists, what is the role of your organization in advancing the safety and respectful care agenda in maternal and newborn health? And what are the lessons you would like to share with us today? Please, because we've started late, I would like to ask your interventions be kept to 2 to 3 minutes. So let's start with you, Franca, please. Over to you.
Thank you so much. Can you actually hear me? You should be able to. Thank you so much, Helga, and thank you to all the other speakers and the whole day who have really highlighted the different aspects of patient safety. And I think it's a combination of them which would help us to move forward. I think I'm just starting my video now, is that right? I keep on getting these pop-ups from the technical people. I would like to highlight a different factor for advancing respectful care, which in many ways is linked to an earlier poll that was done today, which showed that most of the listeners see skilled healthcare personnel as being a really important factor. I feel really proud that the International Confederation of Midwives is truly fueling a wind of change, because the evidence on the impact of midwives it's crystal clear. And the State of the World of Midwifery Report 2021's recommendations, they confirm this. Implementation is still slow because not yet everyone is supporting the latest evidence that shows that if midwives do 90% of sexual reproductive health care, if this were a reality, we could avert more than 60% maternal, newborn, and stillbirths yearly. We're talking about like more than 4 million lives yearly. And I think that we basically all need to recognize that every woman has the right to a midwife, and some to a doctor too. I think that is what we know from this evidence. We need to remember, and I think when you listen to other speakers, we're talking a lot about interventions, but we have to remember that the basis of pregnancy and this is a sign of health, it's not illness. And as the International Confederation of Midwives, we've developed many tools, including our midwifery philosophy of care, that propagates that women and community-centered care is equal access. So not too little care too late, not too much care too soon. We know the realities. I mean, I'm being real, and we know that many women and babies die during pregnancy and childbirth. However, we also know that many die not of pregnancy and childbirth, but they actually die of poverty and of inappropriate under and over care. And I feel that we also, and I've heard it today too, have the tendency to focus mainly on interventions, not remembering our medical oath, first of all, do no harm. I think health has been commercialized and we work with a reward system for interventions. But is prevention, such as, for example, watchful attendance, where a midwife builds trust and watches attentively, is that also rewarded? So as the International Confederation of Midwives, we see that the biomedical model and the risk thinking, so calling women high, medium, or low risk, in many ways disregards the fact that pregnant women are, first of all, human beings, and thinking in risks encourages disrespect and it disempowers women. And I think this counts for all women, in all communities, in all circumstances, and most of all, the ones that are least able to stand up for themselves. And so I think that what we are doing as ICM, we're supporting the implementation of midwife-led continuity of care, where we focus on the long term and involve women in our care. In midwife-led continuity of care, there is a known midwife for a woman and her partner and her family. And so it's possible to build up a relationship of trust. And we all know trust, a lot of it, that's all it's about. Midwife-led continuity of care doesn't mean that the midwife rules. It is teamwork, but it's not hierarchical teamwork, which is the teamwork we often see in institutions. And we see, and we know the evidence shows that midwife-led continuity of care and respectful care, they really go hand in hand. And so we have many tools as ICM to implement this. And these tools will support a more robust education for midwives, regulation of midwives. We support our member associations to look at their own context and develop context-specific tools to strengthen supportive system for midwives themselves. And we see many organizations, for example, supporting midwifery leadership. Your organization, Helga, PMNCH, I think, is doing that. You're supporting more midwife leaders in your organizations. And we see many health doing it as well, getting chief midwives. And I see regretting it. And then last but not least, a growing group of partners has joined a 10-year-long campaign. It's called the PUSH campaign. And 10 years sounds long, but that's because we are realistic. We know that it needs a system change, a real paradigm shift. So it needs a long-term investment and not a quick fix, like certain interventions are. Midwifery is not a quick win. It's a solid long-term investment that will give a return on investment. And so as ICM, we are investing in midwives, because if we want to respect women, if we want to treat women well, we also have to take care of ourselves. So I really look forward to hearing our colleague healthcare professionals join this push campaign, because it should not only be women and midwives calling for midwives. I think this is a joint concern, and we feel that it will make the care and the respect and the safety and security of women and our future and our communities better. Thank you, Helga.
Thank you for that, Franca. So I'm going to go quickly over then to our next panelists, and you did not do well on time. But
oh, I'm so sorry. I'm so sorry.
No, that's fine. Okay, Joe, let's go over to you, please.
Thank you, Helga. I hope you can hear me and see me.
Yes,
And your question is, what is the role of our organization in enhancing the safety and respectful care agenda in maternal and newborn health? I believe from day one, when we started our organization, the Patient Safety Movement Foundation, it was to unite the healthcare ecosystem and make it action-oriented, action out of kindness. To Err as Human is a report that was brought out by Institute of Medicine in 1999, where they showed human error caused up to 90,000 deaths in our country, in the US. Yet, 2011, the numbers seem to be 200,000 to 400,000, and worldwide, millions, and many of them being mothers and infants. So while many people had jumped in to help, it wasn't getting better. And I believed, yes, there's values, innovation, knowledge, expertise, and that might be king, but action out of kindness is God. And we came up with 7 goals. The first was to unsilo the healthcare ecosystem so that whether you're an engineer or a doctor or a nurse or executive or a regulator or a political leader, we all would come together to solve this crisis, because our hospitals should be the safest place in the world. And we should not be dying of preventable harm, because while to err is human, we can put processes in place to avoid human errors from becoming fatal. And we've seen that about 100 hospitals have implemented 40 actionable patient safety solutions we created, which is on the Patient Safety Movement Foundation website. And they're getting incredible results, including Children's Hospital of Orange County, which I chair the quality committee, where nearly now 5 years, we have 0 preventable deaths. The other thing we thought was important was data sharing, aligning incentives, transparency, and bringing dignity and love to healthcare. And in our 40 actual patient safety solutions, number 1 is culture of safety, which is essential. Of course, we have maternal safety actionable solutions, neonatal and newborn. Today, I'm delighted to see WHO have this 10-year patient safety goal, the ministerial summits on patient safety, and of course, World Patient Safety Day. But everyone in healthcare must make sure we have action. We have action out of kindness. And the best thing I think we can do is to deploy evidence-based practices, which we call actionable patient safety solutions, in our daily healthcare. And from the janitor to the surgeon, they all have to be in on this action out of kindness. Thank you.
Thank you so much, Joe. Okay, I'm going to go run over to Jeannie. Jeannie, over to you.
Thank you, Ms. Fogstad, and my thanks to Right Honorable Jeremy Hunt and Right Honorable Helen Clark for their opening comments, which were significant, and Director General Dr. Tedros Ghebreyesus. Distinguished colleagues, today our FIGO societies, which represent the specialists in obstetrics and gynecology from around the world, come together to celebrate World's Patient Safety Day with a particular focus on this year's theme of safe and respectful maternal and newborn care. As organizations, global organizations, we are dedicated to high quality and timely pre-pregnancy, prenatal, perinatal, and postpartum care for all pregnant people. Our societies collectively join the call to act now for safe and respectful childbirth. On this day, our organizations are speaking with one voice to call for patient-centered care, that it be delivered equitably to women around the world. But we realize that the goal requires support from government entities, as we've heard in several of the talks today, policymakers, and a true collaboration with the entire medical community. In particular, it demands attention to those who face pregnancy under high-risk conditions, whether those conditions are poverty, war, racism, violence, hunger, environmental exposures, climate change, limited access, or forms of strife. These are our unique challenges. We recognize the physical impact of pregnancy is significant and complex, and we agree that no pregnant person should die a preventable death, whether it is from hemorrhage, infection, hypertension, or heart disease, and we are thankful for this day and the continued days. Today, FIGO conceived and released 4 statements to guide us. The first is a statement developed by our transatlantic collaboration, the Royal College of Obstetricians and Gynecologists and the American College of Obstetricians and Gynecologists, who created the Childbirth Bill of Rights, which recommends access to safe and respectful care, promotes models for pre-pregnancy, childbirth, and post-pregnancy. FIGO's second statement is an ethical framework. It provides the ethical basis for respectful maternity care during pregnancy and childbirth. Our third statement promotes health system strengthening and respectful care and recommends adopting the International Childbirth Initiative, as well as requesting all governments and health systems adopt the elements of ICI. And then finally, our last statement is about a model for safe childbirth that requires a commitment for all health systems, all healthcare practitioners to provide safe maternal and newborn care. As with all pregnancies, this is our conception date. We're looking to a 9-month gestation. Through our FIGO societies, our FIGO partners, and government leaders from around the globe, the next 9 months allow a full development of a healthy program. What do we have to say about all this? The world has witnessed the largest global pandemic in modern era. We've seen the importance of solidarity and collaboration around public safety. We've heard eloquently from you, Helga, about the concerns of healthcare practitioners and their own risks. So on World Patient Safety Day, FIGO encourages our nations, our leaders, our neighbors, and our partners to apply the same approach to maternal and newborn care and the crisis of maternal, newborn, and child mortality around the world. Thank you.
Thank you so much, Jeannie. I'm going to go over to Naveen, please.
Thank you. Can you hear me?
Yes, excellently.
Okay, so good morning, good afternoon, and good evening to everyone from wherever you are joining. International Pediatric Association is a global body representing the professional societies of the pediatrician, comprising of 164 member societies from 149 countries and representing more than 1 million pediatricians. On this occasion of World Patient Safety Day 2021, IPA is honored to be part of this virtual global conference and extend congratulations to WHO and partners for identifying the theme Safe Maternal and Newborn Care, Act Now for Safe and Respectful Childbirth. It is good to have theme, but we also need a good plan. And IPA also compliment WHO for preparing the Global Patient Safety Action Plan 2021-2030, which is now approved by World Health Assembly in May 21. The framework for action of the plan includes 7 strategic objectives with 35 specific strategies, which also recognize the vital role of stakeholders like international and national professional bodies. IPA is committed to supporting health workers' education, skill, and safety, which is one of the 7 strategic objectives in the framework for action. We recognize the essential need to connect and integrate all newborn and child services with newborn care, whether it is immunization, tobacco smoke, and other environmental exposure, or mental health. IPA's recent technical brief jointly prepared with UNICEF and USAID summarizes the guidance for the safe newborn care during COVID-19, including safe and appropriate use of oxygen for newborn in distress. Our member societies have contributed significantly to the capacity building of healthcare workers on neonatal resuscitation and essential newborn care across the world. IPA look forward to working with WHO once their updated package on newborn resuscitation and essential newborn care is ready. With our reach in member society, we are willing to go ahead and train the health workers across the world. Our experience from the implementation of Helping Babies Survive and NSSK in India we learned that one-time training is not enough. You need to have opportunity for practice and low-dose high-frequency training. We need to provide practice station at facilities, not at the block or district level, which is the case. And then opportunity and a mechanism in place for practicing skill, ongoing mentoring, and a quality improvement plan, a team in place, which also not only looks for the newborn and mothers, but also which integrate all other services. Using checklists and tools to improve quality of newborn care by engaging with all stakeholders involved in delivery process will surely improve safety in the delivery room. We need to engage continuously with local provider to keep track of challenges and solutions possible. With the COVID-19 pandemic, we have learned that remote digital learning can also be used for enhancing knowledge and also some of the skills, and that we could adopt this as a new normal going forward. Already in India, we are using these things for mentoring, for giving training, and also imparting some skills. Finally, everybody, and we also support for the mother, but now is the time that newborns should get due place in healthcare system and respect it deserves. In many parts of the world, newborn is still not counted as independent patient unless he or she is sick to get admitted in newborn unit. As a result, important vital data related to the newborn care, newborn are not captured and monitored, and which may result in the inadequate planning and delay in the care. And this is fact. This is our experience. There are no, if the newborn data is just recorded on the mother's case sheet, and there is no separate say data sheet for the newborn. And unless you don't record all those vital things, it is quite likely that newborn may be neglected. So today, let's pledge for the efforts and commitment to make every newborn counted and get safe and respectful care. And definitely we support as a mother and newborn care together. Thank you.
Thank you, Naveen. Thank you so much. Without further ado, we're going to go onwards to Michelle, who's the chief nurse at the International Council of Nurses. Over to you, Michelle.
Great, thank you so much. Can you see me and hear me okay?
Yes,
I'm hoping?
yes.
Lovely. Good morning, good afternoon, and good evening, everybody, to our esteemed chair and panelists, and more importantly, to all the safety partners here globally and around the world. Thank you for being champions as well. It's my pleasure today to bring to you on the World Patient Safety Day from the International Council of Nurses, who have actually joined with the Council of International Neonatal Nurses in a joint statement, and show you actually how supporting the nursing workforce to deliver safe and respectful childbirth looks in action. We are uniting to call on all stakeholders to take sustainable actions that support the nursing workforce to deliver safe and respectful care and to reduce avoidable harm to mothers and newborns. Our statement being released today attests to the global maternal and newborn mortality from preventable causes that remain high, particularly in low resource settings. Highly educated nurses are working in supportive environments and are key to ensuring the safe delivery of high quality care and to prevent avoidable risks and harms. Nurses play an integral role in providing and advocating for best practices for safe and effective care that meet the health, emotional, and social needs of newborns, mothers, and families. Safe and supportive working environments for the 27 million nurses around the world must be a priority for safety. ICN and COIN have called for 6 actions specifically. 1, onboarding or orientation and training that can be standardized for nurses to care for mothers in anticipating complication, including care of small and sick newborns. Secondly, safe staffing systems that develop, implement, and evaluate, not just for mom and baby dyads, but also considering acuity levels for small or sick newborns and the skill mix of our healthcare workers. Third, addressing gender inequity and tackling gender bias and power imbalances, which undermine the nursing voice and participation in decision-making. Fourth, developing leadership and nursing capacity to eliminate avoidable harm in healthcare will help to enable and empower as well. Fifth, zero tolerance for separation of mothers and newborns is important in this call. And lastly, recognizing families as recipients of care and empowering them to be active participants and partners in care. The impact of nurses in ensuring patient and safety is critical as well. And we're very grateful to be part of the World Patient Safety Day Steering Committee and partner with you all. Nurses are critical thinkers. We deliver care in time, quality manner, and I kept within my time frame and commitment to the partners today for the panel. Thank you.
Thank you. Thank you so much, Michelle. Susanna, we're going over to you from your chair at International Stillbirth Alliance.
Thank you, Helga. I'm the mother of Wilder Daniel, who was stillborn 22 years ago at 38.5 weeks. My pregnancy was happy and uneventful, and Wilder weighed a healthy 6 pounds, 12 ounces at birth. Despite an autopsy, no cause for Wilder's death was ever found. I'm honored to speak to you today on behalf of the International Stillbirth Alliance. ISA is a coalition of parents, clinicians, and researchers from more than 30 countries, and our mission is to raise awareness and promote global collaboration to prevent stillbirth and newborn death and to ensure respectful care. 2 million babies are stillborn every year in the 3rd trimester alone. ISA's role in advancing the safety and respectful care agenda is to combat the invisibility of these babies. Unfortunately, there are many examples of stillbirth being forgotten. The Millennium Development Goals left out stillbirth, so did the Sustainable Development Goals. The global burden of disease excludes stillbirths from global death tolls. If stillbirths were included, they would comprise nearly 1/3 of deaths of children under 5. Stillbirth is not a cause of death, rather, it is an age group which consists of babies who died of many causes and have only one thing in common: their death before birth. No one would think of excluding an entire age demographic from public health statistics, yet stillbirth, the death of a baby before or during birth, continues to be ignored due to fatalism, stigma, taboos, and the myth that investment in stillbirth prevention comes at too high an opportunity cost. ISA works hard to make sure that stillbirths are not forgotten, both to advance prevention and to support parents when babies die. One initiative that we're very proud of is our Parent Voices initiative, with thanks to our funder, PMNCH. The goal is to support bereaved parents to raise their voices and views to be included within the public health agenda. In Kenya, we're working on an advocacy toolkit aimed at helping parents learn about what respectful care looks like, what advocacy is, and how to use advocacy to call for respectful care. In India, our advocacy toolkit focuses on healthcare providers, as we aim to open providers' ears to parent voices. The India Toolkit explains what respectful stillbirth care is and includes practical tools such as a clinician's checklist. Other ISA initiatives include a registry of bereaved parent support organizations in more than 70 countries, which we're currently building on our website, and which will help enable those affected by stillbirth to seek respectful support in or near the countries where they live. Stillborn babies are still being left out. The Respectful Maternity Care Charter does not mention them, yet the rights of mothers and their live-born babies to freedom from harm and ill treatment, to information, to privacy and dignity, are rights that are routinely denied to bereaved mothers and their newborns who are stillborn. Even 1 minute of compassionate, respectful care can make a difference. As the Charter says, women's memories of their childbirth experiences and the treatment of their newborns stay with them for a lifetime. I myself will never forget the kindness of the hospital aide who gazed down at my stillborn son Wilder and told me how beautiful he was. Yet the key players in respectful care for stillbirth, the clinicians who are best placed to deliver it, and the parents who have a right to it may not even know what respectful care is. Simple tools such as a checklist for health workers or a poster listing things not to say to a bereaved parent are critical for educating the suppliers and the consumers of respectful care. Ultimately, ensuring respectful care requires parent engagement. Global public health players need to include parents as allies and experts and provide them with the training and support they need for meaningful engagement. Babies who are stillborn newborns and their parents have a right to the same respectful care that is due to mothers and their live-born newborns. Thanks so much.
Thank you so much, Susanna. And then we're going on to Sandra, last but far from least. Over to you, Sandra.
Thank you, Helga. Can you hear me?
Yes, Sandra, we hear you, and we see you and hear you loud and clear.
Greetings, everyone. I'm an advocate with Wajibon Alliance Kenya and a passionate activist for women's and girls' health and rights. And it's an absolute honor to be joining this conference on this commemorative day. Open quote, "You think this one too can survive? Even if you place him in an incubator, he won't stay for long," close quote. He threw my 2 babies into a cardboard box as I watched helplessly. He organized for the babies to be taken to the morgue, but did not make any attempt to save their lives. I want other mothers to know that they should never keep quiet whenever they're assaulted in these hospitals. These are Marceline Ongachu's words, sharing her traumatic childbirth experience in a public hospital in Nairobi, Kenya. At White Ribbon Alliance, we are a powerful network of advocates working for maternal and newborn health and rights. We mobilize citizens to recognize and seize the power to demand that all women, mothers like Marceline, and their newborns are safe and healthy before, during, and after pregnancy. Poor quality of care has been and continues to be cited as a key contributor to negative maternal and newborn outcomes. We therefore continuously seek, as White Ribbon Alliance, to understand what quality of care means to mothers. In 2018, we went ahead to ask over 1.2 million women and girls to tell us their one request for quality maternal health services. Dear colleagues, the results were far beyond what you and me as health workers, programmers, and policymakers define as quality care. Respectful and dignified care emerges the top one demand for quality maternal health services, receiving over 100,000 responses. This was presented through different expressions like love and care to mother, listen to me, make me feel welcome, doctors must not laugh at a patient, the nurses should not despise. The events leading to, during, and after Marceline's experience speak directly to this top ask. Mothers want to have an interpersonal connection with the health service providers. They do not want to be talked down to. Compassion matters to them, just as any health outcome. So we have learned, one, that we need to humanize the maternal and newborn experience by valuing and taking seriously effective communication as a fundamental pillar for safe, respectful, and quality care. Secondly, we also need to deeply interrogate and address the health system conditions and limitations through the lenses of mothers. As advocates, we are acting on the women's and girls' self-expressed health needs by supporting them to know their maternal and newborn health rights, to speak out, and to collectively take action. We are also working closely with midwives as the primary health caregivers of maternal and newborn care to better understand what is going on in the back end. As a result, White Ribbon Alliance has partnered with the International Confederation of Midwives, and I'm happy to see Franca on this panel, to launch another global listening exercise that seeks to capture the experiences of midwives with regards to their working conditions and profession. Through this and other partnerships, we are keen to connect the voices of women and the experiences of health workers to shift the narrative and practice of maternal and newborn care towards a positive direction through the lens of the mother. As I conclude on this World Patient Safety Day, we urge the world to first listen to women, to mothers like Marceline and Miss Evangelina, who just shared a harrowing firsthand experience, then act now and together for safe, respectful maternal and newborn care. Thank you. Over to you.
Thank you so much, Sandra, and thank you to all the panelists. I think I've been really seeing some common traits between all of you in highlights of really what we've heard also earlier today. If we are to achieve the vision of ensuring everyone has access to safe and respectful care, we cannot operate in silos, and stakeholders must work together as an integrated team, each respecting and realizing their individual professional expertise and harnessing their collective power for betterment of the women and newborns they serve. We heard Franca talk of the teamwork and need for a long-term investment and the push campaign. Joe talked of the need to collaborate and collaboration and clear action. He emphasized the need for action out of kindness that is smart and clear, evidence-based, interventions, as well as data sharing and transparency. Jeannie talked about the importance of making services patient and people-centered, and the importance of ethical framework and health system strengthening a commitment to respectful care, as well as the necessary focus on the healthcare worker and their own safety. Naveen highlighted the need to count the newborn, make them visible. He also called for a good plan that takes the direction clear, as well as education of healthcare workers in collaboration with communities and local suppliers. Michelle called for a supportive environment, evidence-based education, focusing on the importance of the dyad, tackling gender imbalance, and developing effective leadership, and recognizing families as key partners in supporting them. Susanna highlighted the importance of giving mothers voices and the importance of evidence guidelines, simple tools, focusing their respective and dignifying care, as well as the supportive measures to both healthcare workers as well as patients and their families. Sandra highlighted, lastly, shared with us the results of the What Women Want campaign, where women had highlighted respectful care as #1 among their needs, and also focus, similar to the other panelists, the need to empower and equip healthcare workers as well as women and their families. And lastly, the value of partnership. So we have now come to the end of this. Thank you so much, panelists, for your all of your valuable work, critical work, and also for who you are, which is very much based on commitment that really stems from ethical values of caring. So moving on to the second part, we have now gathered questions from both the Q&A box as well as the chat box, and so we're getting and are going to ask our panelists some of these questions. And I'm going to give you 1 to 1.5 minutes, please, in your response. And the first question is from Forum Thacker, and it's for you, Franca, and it reads, how can mothers and their spouses play an active role in safe delivery of their newborn? Over to you, Franca.
Thank you so much for that, Helga. And I think it's such an important question. I think in that too, we need a shift whereby women and their partners or communities, birthing people, are involved right from the start. So they're involved in their care, they are informed well about their care, that they are involved in protocols, that they are involved at every single level. I think what we do too often is that we think that we know best and that we think what is best for the client and don't truly involve people or think that we actually know better. But people don't say things for wrong reasons. People say things because that's where they come from. And I think, so for us, I think we as healthcare professionals, all of us on this panel, we need to listen. And I think that is a hard thing for us, but we need to listen. And on top of listening, we need to truly implement and take it into consideration. You do see it working in certain areas. And I think once we have more time and once the relationships are more human relationships. So again, I think building trust, having continuity of care, I think is very important in that, makes us see each other as human beings. And once we see each other as human beings, we're more able to listen to each other and act on what people need. And so that I think is what it needs. And I think that all of our organizations should in many ways have women's organizations or communities involved with our organizations and in our boards to talk for what they need and what they want. Thank you.
Thank you for that, Franca. The next question is for Sandra. Sandra, what are your recommendations to encourage the community to speak up?
Thank you for the question. Can you hear me?
Yes, yes.
Okay. So recommendations, let me just note, beyond capturing the needs, because it's very important that the community, we get those self-expressed and not perceived needs from the mothers and from the women. So it's very important to organize and to mobilize those needs through such listening exercises like we did. It's not complicated. It's going up to them and asking them their priorities wherever they are. But I think another important thing to do is, even as we are collecting these needs, it's important to then also promote health literacy and health behavior, what we call self-care, because in this agenda, we realize that that ownership does come through self-care through knowledge, self-care through organizing, and self-care through advocacy, speaking out, listening and acting for the needs, and self-expressed needs. And that is how we have prioritized in our organizing as White Ribbon Alliance Kenya.
Thank you for that, Sandra. The next question is for you, Naveen. How can we improve patient safety in areas under development where populations are far away from the healthcare facility services and the health are not enough and doing well?
So that's an interesting question. So there are many areas like that in in India and many other parts of the world. So definitely you have to improve the transport. You have to see that those health centers which are catering to their needs, you have to focus on the staff, and definitely we have to see that quality is maintained, because what we have seen that in such areas, because they don't get a chance to use those skills, and gradually those skills are lost, and so we have to have a different plan for that those health workers can practice those skills, and empowering those health workers by remote learning and remote mentoring, using the digital tools to do that, and you have to focus more. So those are some of the thoughts which come to my mind immediately.
Okay, thank you for that, Naveen. Next question is for Jeannie. It's from Heather Matner. There is a reality that women all around the world are experiencing increasing rates of severe psychologically trauma that is preventable harm, yet it is not decreasing. What are your suggestions for addressing this, as women express strongly that trauma is worse than the physical trauma?
Well, I think we have to put it in perspective. There are two long-term perspectives and a short-term perspective. Right now, with what we've just seen this last year, has been extremely traumatic. But just in this last year, the American College of Obstetricians and Gynecologists pointed out the background risk of depression and anxiety, and specifically around anxiety. Anxiety is treatable, it's recognizable, and it is extremely common. But if we don't even ask women about what situations they're facing, if we don't ask women about their personal conditions, if we don't create some kind of a safe area, we don't even address the issue with them. So I think looking at depression and anxiety and just the stress that women are under in general, and then exacerbated given the conditions of this last year. But you have to be able to recognize and ask women. You can't expect them to bring it up as a concern.
Yeah, thank you for that. Next question is for Michelle. How can healthcare professional organizations work together to improve patient safety?
Great, thanks, Helga. A good example of this would be with ICN. We actually have about 135 countries, and it's national nursing associations that can work together. I think it's important to remember you have local, regional, national, and global partnerships as well. And we need to think about going outside our usual bubbles, not just nursing, for example, and working with a full interprofessional team, as well as working with our community partners, patients and families for that experience, to forward that momentum and the cross-functional work that we need to do. If you build in all the perspectives, and we're truly going to transform a healthcare system that's innovative and responsive, we need to move from a reactive to a proactive stance and include everybody at the decision-making tables as well. Thank you.
Yeah, thank you for that. Next question here is for Joe. Joe, what new digital innovations exist to enhance patient safety?
Well, COVID-19 pushed the digital innovation in the forefront. I believe we saw the use of telehealth and telemonitoring in a way that we thought we may not see for another 10 years. There is now in many parts of the world where you don't have phone lines and you may not have primary care or hospitals, but you can get through the cell phone towers, telemonitoring and telehealth to patients. These are monitors, these are otoscopes, digital otoscopes, and with aid from clinicians anywhere in the world, we can do a lot of good for patients and get them to the right location for care.
Thank you for that, Joe. Next, and this is the last one that we'll have time for, is for Susanna. Why is the issue of patient safety still a major issue today?
For stillbirths, that's a tough one. I think why patient safety is still an issue for stillbirths is integrally related to why stillbirths continue to be relatively invisible on the global stage. There's a misperception that investment in stillbirth prevention and care is, as I said, too costly, that it can crowd out other interventions that will benefit live births. This is simply not the case. We know that interventions can prevent maternal deaths and newborn deaths also will reduce stillbirths. But I think another piece of that is that there's a lack of awareness of the mental and emotional toll that a stillbirth takes on, of course, the mother, on the partner, on the wider family, and on the caregivers themselves. And that relates to taboos on admitting to mental illness or mental challenges or emotional health. It also relates to the taboo on speaking about dead babies, frankly. And these are all issues that we've been talking about today. So I think they're just more intensively focused for the stillbirth population because of that additional taboo against the recognition that stillbirths are part of the maternal health and reproductive health continuum.
Yeah, thank you for that, Susanna. And indeed, it's really as what Naveen was also talking about. There's something about making starting count something that has not been visible and making it count. And there's and so data will be important, and also amplifying and making it more visible. So thank you for that. Thank you to all the panelists. We are really closing in to the end here, and I really want to thank you for not only what you do, but what you have contributed to this panel and session today. Everyone, PMNCH stands ready with WHO and all our partners to address the challenges raised today, working to address safety and respectful care through policy, service delivery, and financing, responding to the catastrophic impact of the pandemic. PMNCH has developed a COVID-19 call to action campaign where we firmly advocate for mothers and newborns with specific asks for better service delivery, quality of care, better human resources for health, and safe facilities. We are, with our Healthcare Professional Association constituency, developing a statement on respectful care. We would like to also see how best to amplify the wide distribution of a policy brief on this topic, as well as to include explicitly commitments on this in our commitment drive. So it is clear that these efforts need to be made explicit on patient safety and respectful care. It is furthermore requires interprofessional collaboration. The associations represented on this panel have a really critical role to play in that regard. Only with a multi-stakeholder collaboration and multi-sectoral action can the vision of universal health coverage for every mother, every girl, every newborn be achieved. So lastly, I would like to thank the panelists and all of you for joining us. Thank you for your questions. Thank you for engagement. Thank you for your work. We will capture everything that has come in, and we will try to get out information in the way that is useful to everyone, so that respectful care and patient safety becomes a reality in addressing. So we will be following up accordingly from PM and CH's side with the organizers. And once again, I would like to thank you all for joining and for participating, and of course for the panelists for all of their contributions today. Thank you.
Thank you, Helga.
Thank you.
And to you and all your panel members for such an excellent final session. Now pass to Neelam.
Many thanks to you, Sir Liam, and thanks to Helga. After impressive diversity of experiences shared, excellent discussions, and stories of effective collaboration during the conference, it's time for the closing session. And I invite Dr. Zuzana Jakob, WHO Deputy Director General, and Dr. Rudi Eggers, Director of the Integrated Health Services Department, for their closing remarks in this session. We are very privileged to have Dr. Zuzana Jakob as the co-chair of the WHO World Patient Safety Day Steering Committee. Dr. Jakob's passion, commitment, and vision of action-oriented campaigns provide us the direction to maximize the impact of World Patient Safety Day. We're very grateful to you, Zuzana, that you can join us. As always, thank you so much for your support and leadership. Over to you, Zuzana.
Thank you very much, Neelam. Dear colleagues joining us from all around the world, as we arrive to the conclusion of our global conference to commemorate World Patient Safety Day 2021, I would like to express our sincere gratitude to all the regions, countries, partners, individuals for supporting this year's theme, Safe Maternal and Newborn Care, and for celebrating this remarkable day in an array of wonderful and creative ways. I would also like to thank all the speakers, moderators, panelists immensely for their great contribution to this event. The discussions were indeed very rich and gave us insight into new dimensions about safe delivery of care for women and newborns, particularly around the time of childbirth. It is encouraging to see people from all walks of life to come together and contribute to such an important cause. I would also like to acknowledge that the excellent collaboration of different areas of work and departments within WHO and across all levels of the organization, which include integrated health services, patient safety, communications, maternal, newborn, child and adolescent health and aging, sexual and reproductive health and research, and the partnership for maternal, newborn and child health has been instrumental in developing the campaign and plans for commemorating the day of this year, in addition to invaluable strategic advice and guidance from the World Patient Safety Day Steering Committee and the WHO Task Force. World Patient Safety Day should not be seen only as a day, but a platform for change and focused initiatives and activities, at least for a period of 1 year. Similarly, it should not be seen only as an advocacy tool, but a stimulus and force to kickstart definitive action to address the huge implementation gap from policy to practice. Last month, WHO launched the Global Patient Safety Action Plan 2021-2030 as the roadmap for action by all partners over the next 10 years. I hope this global action plan will become the cornerstone for patient safety movement and sustainable action across the world, and provide strategic directions to leaders, care providers, partners, and the patient group to achieve significant improvements in the safety of healthcare over the next 10 years. We call upon all stakeholders to commit and implement the action plan in moving towards zero harm in healthcare, and urge healthcare facility leaders, managers, and health workers to sign up to the World Patient Safety Goals 2021, launched today to promote safe maternal and newborn practices. While progressing towards UHC requires different health system elements to be in place and fully functional, through innovative approaches and collective efforts, the foundational principle of any healthcare system, primum non nocere, first do not harm, remains eternal from the Hippocrates times. Without safe care and high quality of health services, UHC will be an empty promise, and communities would lose trust and hesitate seeking access to health services together. Respectful care has also been brought to the forefront of our attention. Too often, many women and newborns experience disrespectful, discriminatory, and abusive treatment during childbirth, which is more common among the most socially and economically vulnerable. Meaningful action to incorporate respectful care into all aspects of childbirth is essential for faster progress in reducing all healthcare-related harm. Our ultimate aim is for every woman to have a safe and positive childbirth experience that fulfills or exceeds a woman's personal and socio-cultural expectations. This includes giving birth to a healthy baby in a clinically and psychologically safe environment with continuity of practical and emotional support from birth companion and care staff. I once again thank you, all partners and contributors, for making safe maternal and newborn care the focus for today's World Patient Safety Day. On this note, I now hand over to Dr. Rudi Eggers, the newly appointed Director of the Integrated Health Services Department in WHO, and from this platform would like to welcome him to our family. And at the same time, I also want to use this opportunity to thank Dr. Neelam Dhingra for her essential work to prepare this day and all the events throughout the year. Thank you, Neelam, and over to Rudi.
Thank you, Susanna, and colleagues. Susanna, thank you for your kind wishes and your words of summary and support. I'm really honored to be part of this team and look forward to work with all of you and the implementers in the country, of course, in achieving these safe integrated health services for all on our journey to move towards eliminating harm in healthcare. So colleagues, as we are still facing the COVID-19 pandemic, it has become evident that safety should be central to all our efforts in providing health services. Reiterating what Dr. Tedros said, we call on all stakeholders to adopt the Global Patient Safety Action Plan 2021 to 2030 as the roadmap for comprehensively establishing safer health systems in all settings and in all areas of work. Further, to allow us to see true improvement in health outcomes, we have to put in place targeted interventions to move from that which we know we should do to that which we actually do, the so-called knowledge implementation gap. From WHO, therefore, we invite all healthcare facilities worldwide to adopt and sign the World Patient Safety Day goals to bring the safe practices closer to women and newborns at the point of care. As I close, let me appreciate also the World Patient Safety Day Steering Committee and all the speakers and panelists and moderators of this day, and the World Patient Safety Task Force members for all your guidance, advice, encouragement, support. You have really shaped the commemoration of this day. Let me also thank my colleagues here at the different WHO departments and out in the regions and countries. The units that have been working with us here are the Department of Communication, Maternal, Child and Adolescent Health, Sexual and Reproductive Health, and then of course, Helga Fogstad and the Partnership for Maternal, Newborn and Child Health. A big thank you also to the ECHO team who have supported this greatly, specifically also this preparation of this event and the technicalities behind this podcast or this cast that we did today. Finally, a big congratulations and a well done to Neelam and her team. Wonderful work and great you have been part of this. Very nice to see up to 1,000 people taking part in this discussion and contributing to it. We hope this Patient Safety Day will be a true catalyst for change of the safety of women and newborns on a global scale. With that, let me thank you all for participating and wish you a good evening and goodbye.
Thank you very much, Susanna and Rudi, for your closing remarks, and thank you all for joining. So before we close, could I request all speakers and panelists to join on the video for a photograph, please? So that our ECHO team could take a picture of all the panelists and speakers together. So, right, I hope that they are able to capture this. So with that, there's just a couple of few points. Please give us feedback how the session was, and if you fill out the feedback form, you can have a certificate of participation. So with this, I would like to wish you a great day of celebration across the world and paint the world orange. If you're in Geneva, please witness Jeddah in orange color this evening, and looking forward to working together with you in our global patient safety journey. This marks the official end of this session. Thank you very much indeed.